Good afternoon, everyone. My name is James Tulski, and I'm a palliative medicine physician and at Dana-Farber Cancer Institute, Brigham and Women's Hospital, and Harvard Medical School. And I'm also a co-chair of the Roundtable on Quality Care for People with Serious Illness of the National Academies of Science, Engineering, and Medicine, together with Peggy McGuire, the president of Cambia Health Foundation, who's my co-chair. On behalf of the two of us and the Roundtable, we would like to welcome you to this workshop today, on integrating serious illness care into primary care delivery. For those of you who may not know, the Roundtable on Quality Care for People with Serious Illness is a group of about 40 participating organizations that come together to discuss implications and of issues related to quality care for serious illness and explore the science policy in this area, and have been serving primarily in an educational role through webinars such as this and other kinds of workshops to advance the knowledge in this area. I'm grateful for the sponsors of the Roundtable, who are all listed here, who represent a diverse group of professional organizations, advocacy groups, insurers, and health systems that are all participating. I would like to note that a recording of this webinar and the meeting materials are going to be available on the event webpage. And at the end of each session, there will be time for questions and answers from the webinar participants. That's all of you. And if you have a question, please enter it into the Q&A box that should be at the bottom of your Zoom screen. I think at this point, most of us are pretty familiar with how to do all of this. Don't use the chat, even if you see it available. I don't think you may even see it, but if you should be putting in your questions through the Q&A, and we can best handle it that way. And the workshop today would only be happening because of an extraordinary group that came together to form the planning committee. Particularly grateful to Phil Rogers and Patricia Davidson, who are the committee co-chairs, and then you can see the names of all the other members of the planning committee that represent really a diverse group of people from a variety of disciplines and backgrounds that can contribute to this incredibly important topic. And I would like to say that this really was the brainchild of Phil Rogers, who is one of the planning committee co-chairs, who just reminded me shortly ago, came up to me at a meeting of the American Academy of Hospice and Palliative Medicine about 4 years ago, and pitched this idea, and then we got it working, and a few things got in the way, but now we are thrilled to be able to present this to all of you. So I'm going to introduce Dr. Rogers, who is Professor of Family Medicine and Internal Medicine, as well as co-director for the Clinical Palliative Care Program at the University of Michigan School of Medicine. So Phil, please take it from here. Thank you.
Excellent. Thank you, James. And I want to start by thanking my co-chair, Dr. Patricia Davidson, who took incredible effort to help me lead this group while transitioning from a position at Johns Hopkins University all the way to Australia. She's joining us at 2 a.m. So her commitment to this work is demonstrated not only by her career achievement, but also her commitment to developing the workshop. I also want to thank the planning committee. We brought together experts from both the serious illness care field and also primary care leaders who really worked hard to put together this workshop. And in so doing, got to know each other, and I think gain a deeper understanding. And that work, the way I experienced it, is exactly the work that we need to do over these next 2 sessions and moving forward. Our goal is to be able to meet the needs of the growing number of Americans living with serious illness. As has been demonstrated in previous workshops, the specialty palliative care workforce is simply insufficient to meet those needs, nor should they be relied on solely to care for those who are living with serious illness. all of us deserve the care we need from the clinicians we know and trust. And our goal is to help continue a conversation that's been happening in many parts of the system, elevate it, and understand how we can do more good work together. You'll see on the screen here some images of bridges. These particular beautiful pieces are by an artist, Marcia Glazier, who spends part of her time in Jacksonville, Florida, which has a number of bridges which she represents in her beautiful painting. And I share these images because the bridge has been our kind of working symbol for this workshop and for how we've developed and created. The idea is building bridges between primary care and serious illness care is the best way to ensure we keep our eye on giving our patients and their caregivers the best experience possible throughout their journey with serious illness. So keep this in mind as we work through today's sessions and those a week from today. Hopefully you'll be able to join us for all or part of that. I'd like next to give you a brief overview of today's workshop and next week. So each workshop will be divided into 2 sessions. The first session today will be an overview of the shared principles of both serious illness care and also primary care. And our second session today will take a deeper dive into the interdisciplinary teams that comprise both of those disciplines. Each of our sessions will be moderated and will include, as James outlined, both brief presentations and then lots of time for interactive discussion and also Q&A. Next week, we'll come back for 2 more sessions. The first session of that day, the third of the workshop, will focus on various aspects of policy issues, including quality measurement, payment, delivery, with experts exploring what's necessary to achieve our goal of better serious illness care everywhere. And then our last session will highlight some programs who are doing this work on the ground today, those who have understood what needs to be done in their communities to deliver high quality serious illness care across the continuum, and hope to learn from that some best practices. Our goal for the workshop is, again, to continue this conversation, to bring good people doing good work together and understand how we can make progress going forward. So when we decided to have this workshop, we thought it would be appropriate to open it with some remarks. And if I could have the next slide. And I'm thrilled and honored today to introduce Dr. Ada Stewart to provide those opening remarks. Dr. Stewart is the current president of the American Academy of Family Physicians. And as an AAFP member, I was thrilled to see her elevated to that position last fall. I was even more interested reading a recent piece in the American Academy of Hospice and Palliative Medicine Quarterly about her work as a hospice medical director. Dr. Stewart has a long and distinguished career, which is fully laid out in our briefing book, but we thought that she would be the perfect individual to help us open our workshop examining that intersection between serious illness care and palliative care. So without further ado, I will hand things off to Dr. Stewart.
Thank you, Phil. Thank you so very much. I am so honored to be able to be with you all today to discuss the importance of exploring the shared principles of serious illness care and primary care. Family physicians and our other primary care clinician colleagues provide care to people of all ages, from newborns to seniors. If we were appropriately performing, we provide comprehensive, continuous care that ranges from prevention to caring for acute and chronic illnesses. We also provide care for our patients with serious illness. Our population is aging and growing sicker. Now more than ever, we need to ensure that the resources are in place that enable primary care physicians and our healthcare teams to deliver high quality, culturally appropriate, palliative, and serious illness care to our patients and communities. Like many of you, I find a story brings focus to the importance of our work. So meet John, a patient living with congestive heart failure and COPD, who I've cared for 12 years, along with his wife and children. I have watched as his condition worsens, his hospitalizations become more and more frequent, and noticed that the talk about his fishing trips have actually decreased. We have had many conversations throughout the years about what we would do when time comes to have this important conversation. And now it is time for me to admit him to my hospice service. So after 9 months of planning his transition, I am at his bedside at his home with his family at 2 a.m. as he transitions. I prayed for him at his bedside. And now I have the opportunity to talk to his wife and his children about his wonderful life and also his death when they come to see me at their regular medical visits in my office. We now have the opportunity to create a better future and a better healthcare system. We need to advocate for innovative payment models that rewards comprehensive, continuous, advanced primary care. Studies have shown how healthcare system built on the foundation of primary care improves outcomes at a lower cost. I would suggest to you that these systems also produce higher satisfaction amongst patients and physicians alike. We also need to advocate for those principles, policies, and practices that provide primary care physicians the resources necessary to accomplish the aforementioned. We also need to address health equity. As Reverend Martin Luther King Jr. said, of all forms of inequality, injustice in health is the most shocking and inhumane. As primary care physicians, and in particular family physicians, continue to work to improve outcomes and address social determinants of health, it is important to realize the impact that we have in driving conversations around caring for patients with serious illness. We all have patients like John. We have the ability to meet our patients where they are and provide comprehensive care to them when they need it the most, at their most vulnerable state. We are a trusted resource for our patients, families, and communities. And we have the opportunity to work together to educate our fellow physicians, patients, and communities on caring for those with serious illness. The AAFP offers valuable resources for our members and the public on hospice and palliative medicine, as well as other resources to help support the important part of our members' work. It is important that we all recognize and realize the importance of caring for those with serious illness and work together to advocate and address issues such as innovative payment models, the development of principles, practices, and policies that will enable us to provide high quality, culturally appropriate care to our patients in life as well as in death. Thank you so much for this opportunity to speak with you all today, and thank you for the opportunity to share my story. Thank you.
Thank you, Dr. Stewart. I cannot imagine a better way to frame the work we're about to undertake this week and next. your vision of comprehensive patient and family-centered care that is both culturally focused and really delivers on the commitment that we make, both as primary care clinicians and serious illness clinicians, to walk with our patients during this most important time in their life. And thank you for setting the tone for our work together. And thank you for your call to action, because I heard that in your comments too, that it is not enough simply to observe that we are doing good work. It is to understand how we drive that forward through structures and supports and policies, and importantly, payment. And of course, we'll get to that in the next week. So thank you very much. We certainly appreciate your remarks, and we look forward to your participation in our first panel discussion as well. So with that, it is my great honor to introduce the moderator of our first session, which, as you may remember and is outlined in your briefing book, will focus on the shared principles of serious illness care and also primary care. And we are thrilled that Dr. Claire Ancuda will be serving as our moderator for the first session. I will refer you again to her bio in the briefing book, but I met Dr. Ancuda when she was at the time, Robert Wood Johnson clinical scholar here at the University of Michigan, where I will work, and we bonded as family docs who also do palliative care. And it's safe to say that Claire is not just a rising star, but a risen star in the field, and really is the future leadership in this important space. So with that, I will hand things off to Claire to start our first session.
Thank you so much, Phil, for your kind words. I am so thrilled to be part of this conversation, and so grateful to the Roundtable for organizing and supporting it, and to all of you for joining in with us. I'm thrilled to welcome 4 speakers for our first panel. Each has a unique and compelling perspective and will set the stage for the rest of our time together. You can read more about each speaker and their full biographies online. First, we'll hear via video, although she'll be joining us in person for the discussion following the presentations, Ms. Shirley Roberson, who's a board member for CTAC, or the Coalition to Transform Advanced Care, and is also a fierce patient advocate and originator of the Blue Chair story. She has been with CTAC for 8 years and has been living with stage 4 cancer since 2008. Next, we'll hear from Ms. Erin Bradshaw, the Chief of Mission Delivery for the Patient Advocacy Foundation. Following that, we'll hear from Dr. Martha Twaddle, the Medical Director for Palliative Medicine and Supportive Care at Northwestern Medicine Lake Forest Hospital and Clinical Professor of Medicine at the Northwestern Feinberg School of Medicine. Dr. Twaddle will give us a perspective on high quality care and principles for high quality care within palliative care. Following that, we'll hear from the primary care side. So Dr. Carlos Jaén, who's the Dr. and Mrs. James L. Hawley Distinguished Chair, Professor and Chair of Family and Community Medicine, and Professor of Population Health Sciences at the Joseph R. Teresa Lozano Long School of Medicine at UT Health San Antonio. So we'll get right started, and welcome to Ms. Roberson, first presenting via video.
I was diagnosed with a tumor first, and they told me that it was cancerous and they would remove it, that it had not spread, that it had been confined, and they did that. They removed it, said I was fine. However, I didn't know what I know now about cancer. I didn't know it's fine really just meant for now. Because they don't add that part to it. They just say you don't have cancer anymore. We don't see any of it in your body. We're going to put you on a pill. So you think you're taking the pill and you're going to be fine the rest of your life. My primary care doctor at the time was none. I was in school. I went back to school at a ripe old age, just so I could finally do what I wanted to do, which was be a nurse practitioner. And I went to classes. I did 24 hours of studying just about, and it left me pretty tired. But it also left me without any insurance because I was told as long as I was working, I could not get any additional help from anyone until I stopped going to school because I could work. So that kind of put me in a situation. Well, as soon as I finish, I'm going to go to the doctor because I need a checkup. So there I was, not being able to go to the doctor, but mostly because I couldn't pay for all the high tech testing that they were doing. I was getting my breast cancer screening, but nothing was showing up. In fact, the day they told me I had stage 4 was the same day they told me nothing was wrong with me. I panicked completely. I thought, oh my God, now I'm going to die. I'm going to die tomorrow, and there's nothing anybody can do about it. And I didn't know what to do. So I called the cancer center and I spoke to a very, very outstanding and supportive person who said, you're not going to die tomorrow. I know people who have lived with this cancer for over 18 years. I'm going to help you through this. And first of all, I want to know who told you you did not have stage 4 here. Who told you that? And when I told her, she got immediately on the phone and started changing things and working things out for me and helping me find the doctor there. And I felt like finally I was getting the attention that I was supposed to get rather than just being ignored because I didn't have insurance. When I connected with the cancer center, I was placed with a group, and I always was against that. I was like, I don't want to sit with a bunch of whining women telling me how bad they feel. And this is what I thought the group would be. And a lot of people still do, but that is so incorrect. The group is what helped me to understand a lot of things. These women were smart. They had gone through a lot, just like I have now. They knew a lot. They knew who to talk to or who I should share things with. But what I also noticed is there was a lot of fear, and they were afraid to talk to their doctors, which I've never had that problem, but I couldn't understand why. And they would say, oh, you don't want your doctor angry with you. And I'm like, why? What will he do to you? He can't. Well, you know what they can do. They can do anything. And I realized it's this pervading fear that's in most patients who have long-term illness, that if they complain, if they're not saying they're doing better, if they don't take, they're like children that are going to be punished. What I learned is that unless you speak up for yourself, unless you defend yourself, unless you're willing to stand up for yourself, nothing's going to take place. And you should keep your own records. I had a very good doctor, and he had other students that would come in. And so they would come in and they would do what they do, I guess, for training. And then I would then see him. Well, this particular day, this very tall gentleman came in, and he had my big, thick folder of medical problems in his hand. And he says, Shirley, I'm going to talk to you about the test that you took, which I took a genetic test to say what chemos would apply and which ones would not apply to me, so that they wouldn't be wasting their time with an inefficient chemo. So he came in and he started telling me the same thing the doctor had told me the week before. And I was antsy because the paper I was holding not only did not say that he had given me, but I already heard what he was saying, and I wanted to hear why my paperwork didn't agree with the doctor's paperwork. And every time I tried to ask him that, he would say, no, no, Shirley, no, I have your information right here. No, meaning the same as shut up. So I said, no, you're not answering the question. I want to know. Yes, I have you right here in my hand. And that angered me. That really upset me. I said, I need you to do something for me. I said, I need you to go and sit in that blue chair. He says, oh, are we going to play a game? And I said, you can call it a game, but it isn't. I need you to sit in that chair, and I need you not to talk as long as you're sitting in that chair. And he looked at me. He says, oh, I see. So he goes and sits. And I continued to tell him, or tried to tell him, what I wanted. But at that point, my doctor came in and he said exactly he says, hi, Shirley, you look a little upset. What's going on? Why are you have that look on your face? And I always carried a notebook, and he always asked me, he says, let's see what's in that notebook today. So he takes it and he flips through it, pulls it back, flips through it, pulls it back, and then throws it on his table. I said, give that back. He says, no. I'm like, you can't keep my things. Those are my things. He says, no, they're not. They belong to someone else. I said, you mean he says, had you pulled the page back far enough, you would have seen a different name. He says, someone in the office has mixed your paperwork up. That isn't yours. In fact, it's going to make me do, he says, now I'm confused. He says, I'm going to have you take a different test again. So that led me to know, first of all, you must question what you're given, and you must review what you have, or you won't know what's going on as clearly as you could. And I did take the test again, and I was right. I did have quite a number of other chemos that could be tried. So I was panicking and desperate for nothing, but I never would have known had Mr. Mouth kept talking. And I don't disrespect him as a doctor. I'm sure he's a very good doctor, but there are times when doctors need to just listen because they don't know. Most of all, the patient needs to feel that you're on his side or her side, that you're not over here on one area and they're in another place. And when I say that, I mean, you're not just an organ, you're not just a breast cancer patient, but you're a human being with human being feelings, and you need him to address you in that way, or to have that kind of compassion and empathy. But I do believe it was that mindset, that comfort, that working together with the doctors allowed me to have the comfort to say, hey, we are trying to do our best for you. And we've included you in on it because we think that you're an important part of this decision. And these are the things I think, if doctors can do this with their patient, instead of just do what I say, here's your pill, here's your prescription. And if you get sick, did you do what I said? I mean, we're not children. We're human beings, and we're perfectly capable of working with the medical field ourselves if we're told, and if we're advised, and if we're comforted when we need it and not chastised.
Thank you so much, Shirley, for those comments. And we will have the opportunity to discuss more with Shirley later in the panel. Next, I'll welcome Erin Bradshaw.
Hi, thank you for having me. So thank you for allowing me to talk today. I'm going to be sharing my experience as a leader and a supporter of Patient Advocate Foundation for the past 23 years. My experience with PAF has really been something I'm motivated and passionate about, improving the lives of patients around the nation. I joined the organization as a case manager, providing direct intervention to patients, and learned firsthand that many inequities that many face. Today, I offer executive operational leadership to fulfill what has always been the heart of our mission, and making sure that no patient is left unserved. This has never been more motivating to me, and our dedication to finding solutions is more evident. For 25 years, Patient Advocate Foundation has served as a leader delivering effective, compassionate case management intervention to patients nationwide. We have primarily supported those with limited resources, not only patients and caregivers, but also those that are coping through these very complex chronic conditions, helping them find safety net programs and other assistance important to dismantling some of the existing obstacles that they are facing to gain access to equitable quality of care. Health equity and diversity and inclusion are embedded and are at the core of our person-centered agenda, enforcing what matters to individuals as people beyond their disease, while identifying and addressing those unmet health, financial, and social needs with an emphasis on supporting limited resourced and underserved populations. Next slide, please. Financial distress is very real for many. With every diagnosis, patients' families face direct costs for medical visits, medications, and treatments, as well as indirect costs like transportation, expenses to getting to care, and the support that they need at home, as well as deteriorating health circumstances that interfere very routinely with their ability to work, earn income, maintain health insurance coverage, and often unpaid caregivers that are also taking additional financial responsibilities associated to the child or adult care, and find themselves balancing their responsibilities of work and home responsibilities. The harms are particularly prevalent among the populations with low socioeconomic characteristics, communities of color, and those living in rural regions or medical shortage areas. In 2019, Patient Advocate Foundation surveyed our patients, seeking some feedback on their top concerns and what was really important to them. As this slide indicates, the results reflect an underrepresented limited resource population, often voiceless of their primary concerns, and alarmingly shared that avoiding financial distress worsened by chronic or critical illness was truly the #1 care goal that they had, representing 63% of patients served by the organization. Notably, a higher concern than the possibility of dying or even some of the side effects. These findings align with what case managers hear and address every day. This is a very real thing for people, and the importance of the untold story behind health inequities. This is an opportunity for us to build upon your roles and help get people what they need and care about at the time of diagnosis and on. Next slide, please. The services offered through Patient Advocate Foundation and others fill in often overlooked aspects or inconsistent offerings for the quality of life outside the medical setting. These communities that we serve have long endured unequal access to care and challenges created by many social determinants of health. And the pandemic has drawn a much needed public awareness of these inequities, while also intensifying the need for the work that we do at the individual community level. The simple truths are, the financial and social needs navigation is essential to patient and caregiver well-being. Avoiding financial distress is a top concern, as reinforced by the slide prior, and optimizing person-centered communication is key. Patients and caregivers are forced to be their own general contractors of their own healthcare. Navigating support is a lifetime. Many patients and families face the difficulties of managing the total cost of care during what would often be a long course of illness. It is notable that you will hear in the next workshop from a patient and National Patient Advocate Foundation volunteer, Michael, who's going to reinforce these truths for you. Next slide, please. The opportunity is now. We have a very timely opportunity to use these findings and normalize needs navigation as part of a primary and palliative care practices, expanding beyond the important support upon diagnosis and provide a holistic support to all. The current system patient-centric healthcare model is just not meeting the needs of the patients in their communities. People often are forced to sacrifice basic necessities to pay for or adhere to recommended treatments. This type of total cost information is typically unknown or overlooked because patients, especially those in underserved communities, are often disengaged from efforts of collecting their experience and perspectives, and even more removed from decision-making and dissemination. As we are addressing the financial stress that we know is very real, clinical practice guidelines can standardize needs navigation to ensure quality standards and help fill these gaps in the health systems and address patient and caregiver needs. PAF has been providing the solution for over 25 years, far beyond the topics that are presenting today, always meeting the patient to where they were and ensuring that they were able to get to solution. This is not only a professional motivator for me, but a very personal one. I'll quickly share an experience I'm going through right now with my aunt, recently diagnosed with breast cancer. She has been diagnosed and has excellent medical care and has been navigating through the course of her treatment. Originally diagnosed with stage 3, has advanced due to some complications that she had from a hospitalization and subsequent sepsis from an infection. But what we learned very quickly, and I have the knowledge and navigation ability to help her, is that upon her diagnosis and what she thought was a very easy access to medical leave at her employer, quickly unraveled. She was put out of work due to the complexity and the severity of the treatment that she was having and how sick she was getting. She went ahead and put in some medical leave at her work, assuming that her disability would just be pretty routine. As soon as she was out and in the midst of treatment, we learned quickly that she was actually just over a month shy from qualifying for a disability benefit, leaving her completely without financial assets or resources to support her everyday cost of living. In addition, her medical leave was only securing her for a limited amount of weeks, and after that, she was subject to lose her employer, her job, which was going to impact her health insurance and her livelihood in that means. So as we continue to navigate each one of these situations, it was something because of my ability and way I was able to address them and my knowledge and just my understanding of how to engage that I was able to eliminate some of these stresses and help her go through them. I'm fixing them through some safety net solutions and helping through a lot of family support as we help get her through this treatment protocol. But that's the importance of why we're talking about this today and why we need to standardize and normalize navigation for all through primary care and palliative practice. Next slide, please. I will close in sharing what strategic steps it will take. I'm sharing from the voices of those that you typically don't hear. I'm sharing from the voices of the Patient Advocate Foundation's patients and are usually not included in research, but we know what they need and served, and I'm going to be their voice. We need to coordinate research, policy, and advocacy actions to advance the work of social determinants of health screenings. We need to standardize needs navigation as a viable intervention. I will be followed by Dr. Twaddle, who will be talking about the guidelines and palliative care clinical guidelines. And we need to use this as a stepping ground as we look at needs navigation through support. We also need to measure the impact of patients and communities and programs and scale these evidence-based approaches to increase quality and expanded availability. We need to take this and normalize needs navigation for all and make it part of the solution. We know patients have access to care. We want to make sure they have quality, equitable care. The activities and benefits will benefit hundreds and thousands of diverse patients and families living in marginalized and underserved communities across the entire country. I welcome you all to join us in this effort, and thank you so much for the opportunity to speak today.
Thank you so much, Erin. Next, we'll have Dr. Twaddle.
Thank you so much. I really feel honored to follow Shirley and Erin, and it takes a village to care for those with serious illness. And I think These two amazing souls have really helped us to begin thinking more about the multifaceted needs of those with serious illness and the requirements to support them. I'm going to speak about our quality guidelines, our clinical quality guidelines, because I was a primary care internist in my first life before I focused on the seriously ill and became a specialist in palliative care. And in these 32 years, I'm very grateful for the evolution of these clinical practice guidelines and how they help to outline the essential elements of what is quality palliative care and help to reflect the multifaceted needs of people and their caregivers as they navigate serious illness. So guidelines, as we know, help to define the structures and process of care, help set expectations, help us to set standards and measurements, help in decision-making, and also inform policy and payment. Next slide. A little bit of history of the national guidelines for quality palliative care. They started in 2001. The first publication took about 3.5 years, the gestation of an elephant, but the process was the product as well, because those initial guidelines and that process that then led to publication in 2004 helped create the National Coalition for Hospice and Palliative Care, which endures to this day and actually has expanded in terms of stakeholder involvement. The last set of guidelines was published in 2008 on Halloween, and it was a beautiful process, I must say. I had the opportunity to co-chair that process with my beloved colleague, Dr. Betty Farrell at City of Hope. And watching this come together, and also the rigors of a evidence-based systematic review, was very helpful in the process of bringing this forward. This effort was funded by the Gordon and Betty Moore Foundation. We continue to be very grateful for their support in the 18-month process to bring forth the 4th edition. Next slide. So the edition is very accessible. And as we think about primary care physicians, practices, integrating the guidelines, they want to have these at their fingertips. And I invite you to use the online version, as I think it is one of the most user-friendly. I am on it frequently. You can print what you need. You can search for certain terms, etc. And it helps very much to have a large document easily available and able to focus on what it is you need. Next slide. The guidelines use the term serious illness. They very much speak that this type of specialty palliative care and palliative care provided by non-specialists are for those people who are seriously ill. And we use the definition that was put forth by Doctors Kelly and Bolins-Lund, that a serious illness is an illness that has a higher risk of mortality and negatively impacts functionality, which really makes us stop and think that we need to be measuring function, or quality of life, or excessively strains one's caregiver. So very important in this definition, there's nothing about prognosis as the definition of serious illness, but really the burden of the illness itself and its impact on that person. Next slide. The guidelines emphasize again and again that palliative care, by definition, is interdisciplinary care. When I, as a physician, meet with a patient and provide a consultation, I'm practicing palliative medicine, medical discipline. When I engage with the rest of my team and take into account and work with them to formulate a holistic, multidimensional perspective of how to best support this person and their family, that's when this becomes palliative care. So interdisciplinary care is critical. And in that interdisciplinary model, we talk a lot about the C's. I use them many times. The comprehensive assessment, coordination of care, care transitions. And in particular, what was really exciting in this last iteration of the guidelines is the emphasis on supporting the caregiver. One must, of course, assess for unmet palliative needs for the person who is seriously ill. But these guidelines assert that one must also assess for the needs of the caregiver and the caregiver's capacity to be in that role and whether or not they're at risk for burnout or excessive stress, because it takes a village. And as Erin so well pointed out, sometimes it takes more than just that formal caregiver. We need to access additional caregivers and navigators. Sensitivity to culture and ethnicity, and inviting from the patient and family what they would prefer as far as communication. My first question to patients always is, how much information do you find helpful? Not to make the assumption that everyone wants every bit of information, but that this might be really tailored to what they need. And also that critical question is, who do you like to have with you when you hear information that could be life-changing or redirecting? Who else needs to be here with us, even on the phone? Next slide. This little diagram shows how the interdisciplinary team works. And by definition, the interdisciplinary team is the hand, in the sense that we have role blurring. So that what that means is we can screen for unmet needs outside our area of expertise. So myself as a physician, I can screen for unmet social needs, but the assessment, when that screen is positive, is done by the social worker. Likewise, I can screen for unmet spiritual needs, but the assessment, the deep dive, is done by the spiritual care provider on the team. So this little diagram of screen and assess is really how we deliver care in the interdisciplinary model. I will say that none of us can practice without a social worker, and that the social needs and social determinants play such a huge role in the care of seriously ill people, that is such a critical component. What we found in community-based palliative care is many times the active piece of spiritual care is there from the community. The secret is, how do we integrate those people into our team to improve communication? Next slide. The domains of care is how the framework of the guidelines are constructed. Structure and process of care being the largest guideline, detailing what is the team composition, how do we do what we do, talking about transitions of care, and then the different domains as we assess the patient, screen the patient within those different domains. Care of the patient at the end of life obviously doesn't apply if we're doing upstream palliative care as much as it does when we are caring for someone in hospice. And hospice is a form of palliative care that's well supported by a robust insurance benefit. We'd like to see that across the whole continuum. Next slide. Little bit of the actual guidelines, just as an example. So each guideline, in this case, we're talking in the structure and process of care, talking about the composition, the guideline around the interdisciplinary team. You can see that there is a description of this and then criteria below this. Next slide. What is very helpful as we look to integrate these clinical practice guidelines into our everyday practice is, what are the clinical implications of this guideline? What does it mean to me? How do I anticipate its operational implications that's actually addressed in the guidelines? And what I am very excited about is it says the essential palliative care skills needed by all physicians, not just specialty level. These guidelines are not intended to be only for those practicing specialty level palliative care. This is a team sport, and the integration of folks who may not call this their specialty, but very much are involved in the care of the seriously ill is what we want to help equip and empower. Next slide. Within the guidelines are 45 practice examples, and these are real. These are examples from all over our country of how communities or services or groups of people found a way to meet the needs of the seriously ill in their community. One of the things it reminds us of is that we can't hire everybody onto our team that we need to care for the seriously ill. We have to look beyond who's right there to who else we can work with to help us in care delivery. So we have to create our teams. There are some essential folks, depending on our population, that I feel we really need to have very closely knit within our practice model, but we may be collaborating with the community-based spiritual care. We may be collaborating with care managers from certain agencies, et cetera, in order to meet the very diverse needs of our patient population. So these 45 examples are inspirational. I think you will find within them some, that sounds like our situation. And their creativity really helps to give us ideas of how we can meet the needs of this patient population. Thank you so much.
Thank you so much, Dr. Twaddle. And now we have Dr. Haim.
Good afternoon, greetings, and thank you so much for the opportunity to participate in this conversation. I find the previous presentations by Shirley, Erin, and Martha very much aligned to the principles of primary care that I would like to outline. And I think that one of the things that we share as both palliative care clinicians and primary care clinicians is sort of the focus on the biopsychosocial model. So let's go to the next slide. And you know, we have all heard about it. We talk about the different domains, but Borrell and Carrillo, along with Ron Epstein and his group, had really emphasized some of the issues related to what we have been talking about in terms of what is the type of, what are the pillars that are provided in the context of the biopsychosocial clinical practice. How do we make this, how we take this philosophy of clinical care as a practical guide? And I think the pillars are related to self-awareness. So as clinicians, we need to be very aware of how our activities, our work are connecting to the patient in their context. We need to have an active cultivation of trust. The example that Shirley shared with us, where the conversation, the cultivation of trust was not happening. It's a great example of also the important need to have that as part of our practice. An emotional style that is characterized by empathic curiosity. We need to know more about who is this human who is in front of us. They are more than just the sum of their systems. They are people who have, and we need to be able to assist them with our whole humanity and affirm their whole humanity. We also need to be very mindful of self-calibration as a way of reducing bias and questioning the things that we are assuming or in the context of our process. And we need to be educating the emotions to assist in the diagnosis and forming therapeutic relationships. And we need to use informed intuition and communicating clinical evidence to foster dialogue. So that's a base that I think we share. And if we go to the next slide, I would say that I would like to sort of briefly take a moment to reflect on a couple of some of the family medicine writers that I think provide a significant framework in our conversation. One of them is David Locksterkamp, a rural physician in Maine, who is a great writer, but he writes, I believe the family doctors will always be generalist trained, relationship-centered, and community-oriented. We are generalists not by virtue of what we do or know, but in the way we ask questions and construct solutions in response to the suffering of those who sit before us. We trust the looping arc of conversation, one that leads to a deeper understanding and sense of belonging. We know the value of patience, reassurance, and gentle guidance, of talk when impatient action would suit only the doctor's insecurities. So I find that very inspiring and also very, very related to the context of what we're talking about today. The next slide. Another sort of great thinker and father of family medicine, Gail Stevens, has a very sort of motivating essay related to sort of the horror of dying. But he writes, what could be of greater comfort and safety to patients and their families than to have a trustworthy physician as a counselor and advocate during the vicissitudes of a critical illness, chronic progressive disability, and dying. That and a loving family are the best protections that I could wish for myself or anyone who wants to avoid the horror of dying. Again, I think that these are for those of us who are primary care doctors, particularly family doctors, it resonates with how we approach caring and how we take care of our patients. And I want to emphasize what both Phil and Dr. Stewart have highlighted is the fact that the needs for our populations are not sufficiently met with palliative care physicians. We need to activate and affirm and support primary care participation. If I could go to the next slide. So the three organizations, the four organizations that are primary related to primary care, the American Academy of Pediatrics, American Academy of Family Physicians, American College of Physicians, and the American Association of Osteopathic Medicine, have agreed on some shared principles of primary care. I will not go into depth at this point, but I just want to place them in the context of our conversation because I think they very much are similar to the principles that are being articulated before by Dr. Twaddle. Person and family center, continuous, so is that relationship over time. It's comprehensive and equitable. It's team-based and collaborative. It's coordinated and integrated. It's accessible and it's high value. So there's a lot of resonance between the two groups in terms of that context. And if you can have the next slide. Next slide, please. On May 4th, the National Academies of Science, Engineering, and Medicine released a new report of implementing high quality primary care, rebuilding the foundation of healthcare. It was released on May 4th, and it provides some guidance also to the particularly the policy issues and the implementation issues that the two groups can potentially synergize to make it work. Can I get to the next slide? One of the contributions from the report is a revision of the primary care definition that was initially posed in 1996. The new definition articulates primary care as a high quality primary care is a provision of whole person, integrated, accessible, and equitable healthcare by interprofessional teams that are accountable for addressing the majority of the individual's health and wellness needs across settings and through sustained relationship with patients, families, and communities. So this definition places the agency in an interprofessional team, and it really emphasizes also the role of communities in this context. Can I have the next slide, please? There are 5 objectives for achieving high quality primary care that, again, I will not discuss in detail, but I would encourage you to look at the report and read more about it, because I think, again, there is a lot of potential good guidance. One of the objectives is pay for primary care teams to care for people, not doctors to deliver services. For a long time, we have been focused on somehow competing for funding and articulating that primary care is going to save you money. I think that's the wrong argument. In fact, the report highlights the fact that primary care is a common good. Just like public education or others to make it do it, we also need to train primary care teams where people live and work, ensure high quality primary care is available to every individual, and ensure high quality primary care It's implemented in the United States. Can I have the next slide? So primary care can be a bridge to palliative care. It's an opportunity for collaborative optimal care with palliative care. However, some patients, particularly in my community, are blocked from getting to the bridge because they don't have access, or some get to the bridge too late. Many primary care clinicians welcome the opportunity to accompany their patients during the difficult journey. And I had to tell you, next slide, from a personal experience, this type of care provides a wonderful opportunity to experience gratitude and to really affirm and prevent the burnout that often accompanies intense personalized practice. Again, thank you very much for the opportunity to participate.
Thank you so much, Dr. Hayin, and thank you to all of the panelists. It was so helpful to hear everyone give such a nuanced and interesting perspective from your own lens on what our shared ground is. So I'd like to remind everyone listening to the webinar that you can feel free to enter questions in the Q&A box. At this point, we'll move into the panel discussion. And so I'll invite all of our panelists, including Shirley, can hopefully join us in person, to turn their screens on and join for a conversation. Wonderful. Let everyone come on. Great. So I think I'm going to start with sort of a simple question, just to give everyone a chance to sort of summarize what they heard. I think Carlos, had the advantage of speaking last and hearing everyone else, and really just commented on how much our fields have in common. And indeed, there are many of us listening who practice both palliative care and primary care. And so I wonder if, just again, in a few words, if you all could talk about, from your perspectives, what is our shared ground? If we're thinking about building the bridge, what are the principles that we need to really most keep in center? And then separately, what does palliative care uniquely bring to the table and primary care uniquely bring to the table? And we can start in any order. Maybe Martha, would you like to start? And then we'll go from there.
Yeah, so they are so integrated and so interwoven. To me, I am a primary care internist who's focusing on a specific population with serious illness needs. And I have the joy of that being my only focus. Though there are days when I miss just to give me a UTI and I would be really happy. But they are so much interwoven. And I think in particular, as Carlos spoke, the model of approach is absolutely the same. Is this idea of relationship-based care that is focused on the person and the family, and the population is what defines who we're focusing on. And our guidelines are to equip all of us to provide that care.
Next, Dr. Stewart, would you like to comment on that?
So going second was really tough because Martha really, she was spot on. It's all about relationships. It's all about being able to have the tools necessary to be able to do what we need to do. The one thing that, as soon as you said, who's at the center, it's the patient that's at the center. It's the patient and the family at the center of it all. And it's about those relationships that we have with our patients as primary care that really help us to be able to transition from, just taking care of those chronic illnesses to being able to care for the serious ill, and also to be able to provide palliative health for our patients and the community and the families that's involved. So that's my take on it all. So thank you.
Carlos, would you like to go next?
Yeah, I like to. So I want to echo that. I think that the role for primary care is in the longitudinal relationship. So, I recently had a patient who died. I was his doctor for 12 years, and it was a relationship that, as he is being resuscitated, his wife is calling me to say, this is the situation, this is what happened. And as I go to his funeral, his pastor is saying, he is here, our doctor is here. And it's that type of relationship that goes over time that is priceless. At the same time, I think that the synergy that comes from working together with our palliative care colleagues provide that transition. I had another patient who recently was diagnosed with stomach cancer, very disseminated, and she had no insurance, she had no resources, but we were able to connect her to a hospice that provided the pro bono care. We had the family meeting, we connected, so it was a joint venture. So I think that is one case. And then the final thing that I want to say is there are some patients that meet the definition of serious illness that Martha was, but we don't commonly think about it. And I want to propose, for example, diabetics, men who are diabetic, who are in construction, who end up having amputations. They fit the definition, but we don't traditionally think of young people who no longer can have a way of living because of the working conditions being in that process. So I think it is, in some ways, we have to be careful not to medicalize it so much that we lose sight that there are other ways and things can happen, particularly for poor and less resourced populations.
Erin, would you like to add anything to the question?
Sure. I just like everyone shared, I know the importance of the medical care and the support that they're getting through primary and palliative is extremely important, but also really meaningful identity and addressing of patient and family directed priorities that often come from those additional support needs that may or may not be able to be identified or known, and that importance of that holistic and community-based healthcare approach that will help support patients' unmet needs that are happening at the hospital, clinic, or pharmacy.
And finally, Shirley, you're welcome to add any thoughts you have on sort of this ideal heart of, you know, high quality primary care that is also palliative care. Oh, I think you're muted. You're still muted. You can type in the chat box to me and I'll read your comments. How about that? Okay. In the meantime, while you're doing that, we are getting many questions from the audience. So I'm just going to start throwing them out and we'll get through as many as we can. So the first question I'll pose is, what is the priority to integrate palliative care and primary care? Is it more collaboration between primary care clinicians and palliative care specialists, or is it training primary care clinicians to integrate primary palliative care principles in their practice?
The answer is yes.
Yes. I was going to say it's both. We don't have enough primary care specialists in this country that every person will have a specialist, and we don't necessarily need that either. So it is very much about equipping and empowering and these relationships and creating networks to help support our primary care physicians and APPs who are engaged in this care and helping them. Creating team.
Yes, it's all about team, and really, you know, it's important that, you know, we recognize that it's not one versus the other, it's together, and having, you know, both to be able to take care of our patients and to take care of our nation, and to make sure that they, everyone has the opportunity to have high quality, as I said, culturally appropriate and equitable care. And that's the only way we're going to be able to do that, to have all hands on deck, to have everyone, you know, have the tools to be able to accomplish this goal. That's where we need to put more of our emphasis.
And to recognize that it's not a smooth continuum per se. Just like you said, Carlos, we don't often think of the diabetic patient. There are patients that I serve in the care and use my palliative care skills that I then don't see for years, who then may come back and again have the need for that holistic, multidimensional support that they didn't need when they were kind of in the well baby care. So it is about using this approach, the essential elements, and applying them to the right population. And it may wax and wane, ideally, over decades versus just be an end of life type application.
And Martha, one follow-up question specifically for you. There was a question about elaborating on strategies to disseminate the guidelines. How do we disseminate training?
So there are more and more opportunities, I think, within training in palliative care. There's a couple of institutions that have put forth online master's programs if people want to get advanced training and become a local expert. There's also through the Academy and through the network of people, somewhat of a Project Echo-like approach where we can access experts and call the experts, so to speak. And with this growth in COVID of virtual, I think we're going to see more and more opportunity to formally help and coach so that we could come together in grand rounds types of discussions or case-based teaching that will help us not so much disseminate the guidelines, but apply the guidelines to the patient population we're caring for. How are they relevant to me today in the care of my patient? And how do I use them? We've done a lot of work. 80 organizations endorsed the guidelines at publication, but how to make them fit for myself as a primary care physician is really the next iteration that we want to explore.
Next, I have a question specifically for Shirley. So the question for you is, I think we heard from all the panelists this importance of patient-centered care. And in your story, you really demonstrated your own need to advocate for yourself when the care was not centered on you as it should be by, asking the right questions and sort of demanding that time that was so important. The question from the audience member is, what thoughts do you have about how we enable and support patients to have this courage that you clearly possess when you're speaking up to doctors?
Well, you have to have this really strong desire to stay alive, for one thing. And I'm very serious about that because I've asked many people in my group, a lot of times when they're sad, depressed, they're coming in about something the doctor said or didn't say or did do or didn't do. And when I ask, why did you not bring that up? It's the same response. It's like, well, what, I'm just a patient. I'm just a patient. They're the doctor. You can't tell the doctor what to do. And indeed you can. And he may not listen. I'm not saying that, but you can do that. And I think we need to be encouraged as patients to inform, to say when we're not satisfied, to say, just like the person who was just talking, I didn't quite understand the difference between what you were making between primary care and palliative care just then. That just went right over my head. And I'm not sure now what the difference is. I was a minute ago, but now, you added a few extra words and that just threw me off. But we should be able to be not necessarily any disrespect intended to the doctor, but be able to say, hey, I didn't get that. And a lot of doctors do not like that. I have been told there's only one doctor in here and that's me. And I said, not anymore. And I left. So, you should not have to be treated that way. I hope that answers the question.
I think it's really important and one of the competencies of palliative care is around communication and making it about the patient, is setting the stage for how the communication needs to be and that we're sitting at the same level. And I usually spend some time talking about what I mean by shared decision-making. And shared decision-making is that you have the experience of living with this illness. I have knowledge, but you have experience. And we have together an opportunity to make better decisions in your care. And I invite and encourage your rebuttal to any recommendations I make, because I need your input. We can't do this together if we aren't really working on it together.
Well, maybe you should, I'm sorry. Somebody else was talking? I think maybe you should share these kind of ideas with each other, because that is not the majority. That is not even the small majority of the thinking that I have run into over the 13 years of dealing with doctors. There's very few who even care to take any extra time, if you will. They'll remind you their patient's waiting. Okay, well, I'm waiting right here and I waited all day. But you usually don't say that, you just get it over with. And so we get further and further back. Why can't we be encouraged to go to the places where we need to go to find out our own information then? Write down, I know my doctor does, write down a couple of areas where I might be able to look up one of my medications and get a little more information on it, because that's what I need. So palliative care and primary care, they run into each other a lot with me. And you don't know who to ask what's the right thing. The primary care will say one thing, the palliative care will say another, and the specialist goes and just goes over everybody's head and say, no, I don't want you taking that. So what are we going to do? Where is the line drawn, and how do we stand up to what we want instead of saying, well, no, I like that prescription. It works for me. I want to take it. So I don't know how we change that. And I'd like to, because some of the medicines that the palliative care doctor has given me have worked very well and made me feel so much better, but my oncologist has taken it away from me. So I don't know what to do about that.
You know, that's the importance of primary care and of especially, you know, family medicine. You know, we talk about comprehensive, coordinated care, and, you know, I encourage my patients to you know, create a list, some of the items, because many times we know that time, those office visits are often limited. We have patient portals where they can reach back out at a different time to talk with me about different issues or concerns they may have. Most of my patients are very spoiled. They actually have my cell phone number. So that's another conversation to have. I would not encourage that, but it works for me. But, you know, to talk about, and as family physicians, many of us make sure that we discuss communication and how to communicate, how to make the most of each visit, you know, and let our patients know that it's a partnership. I tell my patients, you know, I can't go home with you. You know, I can guide you. I can let you know what is good, what are the truths, what are myths, what are things that, you know, I may not know, that we can together, again, those shared decision-making times to make decisions, and especially when it comes to serious illness. You know, as I talked about my one patient, John, you know, for years we had conversations about what will happen or what could happen as his disease progressed. And it was about what he and I came to the conclusion of how we will proceed as the illness went on. And those were decisions that he and I had. There was times where, you know, I may not have agreed, but, you know, I listened. And I would say that many, and I'm so sorry, Shirley, that you did not have someone to really be there for you at the time to really listen. But I can tell you that many primary care physicians, many family physicians are out there, and we learn, as Martha says, you know, how to communicate. There are informations out there, resources that our academy, the American Academy of Family Physicians, have out there on how to communicate bad news, how to communicate with your patient about serious illness. So there are resources out there, but again, we have to make sure that physicians know that the resources are out there, that they need to access them. And for us, it's really incumbent upon us who really know these things to teach our colleagues, to teach our patients, to teach our physician colleagues on how to do what they need to do to make sure that their patients receive the best care and that is of high quality. So we're there, we're trying to do it. And I want to make sure that as I move forward as president of our academy, that I continue to promote this and make sure that we know that this is really important work that we need to embark on.
Thank you.
The other part of communication that is also important is that one of the key functions of primary care is coordination. So it's not only communicating with you, but communicating with the people who are treating you. So if there is a discrepancy, it is really incumbent upon us to then reach out to that clinician and to say, what gives? What are you thinking? You're not listening. That we are also to be patient advocates in a very proactive way. So part of our job is to be your ally and to be with you walking in this journey. And, and that sometimes means that we're going to disagree with the specialist who's giving you a recommendation. And it is our job to then reach and connect and make that happen. So I think that's an important piece to do it. And I just want to go back to, you also mentioned, Shirley, that, they don't have time. It's too hard. It's true. It's very short. But I think that brings us back to the new report and the policy advocacy. And in fact, that report also highlights the need to have one person in the Health and Human Services department to coordinate primary care, to make sure that the resources are there. Our country spends only 5% on primary care. Mm-hmm. Most big countries spend 14%.
Yeah.
Part of that primary care is the care that the palliative care patients, physicians are providing. So we need to advocate at the national level for coordination, mm-hmm. and then for have a way of measuring our progress as we go towards that.
Here,
but your primary care clinician has a responsibility to coordinate and to be your advocate. And I think that you need to be able to say, hey, speak out with me. That's not acceptable. And I think that that is part of, I think, our commitment to you as a person. We're here to be with you for the whole journey.
Thank you.
I wonder if the others have comments on this issue, that I see a tension in the comments of many questions about education around palliative care skills for primary care clinicians, many other questions around how do you do this in a 5-minute office visit? And I hear that tension here, and I wonder from Martha's perspective, Ada's perspective, if you have anything else to add on how you overcome this barrier of limited time.
Well, I think it's important that we manage our schedules. We're on a gerbil wheel, I realize, within healthcare, and this has been an ongoing pushback and negotiation with even the powers that be where I work, that these patients are not served in 5 or 15 minutes. And if you really want to make a difference, that initial consultation, my initial consultations are an hour long. All my visits are an hour long. Because of these people have multiple complex illnesses, they take time. And especially if we're going to involve the family. So to expect the patient to come back for a multitude of 5-minute visits does not serve that patient. It's not efficient. It's very costly. So we need to restructure our offices. And this is where it speaks to the interdisciplinary team model. When I did primary care, I worked alongside an APP. I did the initial visits. They did the follow-ups. We did incident to billing. We made it work. We have to restructure the way we're delivering care is that piece. And maybe I'll just bracket the education. We can come back so my compatriots can also speak.
You know, it's really important that with that, you know, we're trying as the AAFP and other primary care organizations to really change the way payment is focused. Right now, you know, it's more fee for service. So the more patients you see, the better your payment. So it is a bigger argument for that value-based payment. That is really going to have to change. You know, as Carlos said, you know, we really need to put more value on primary care and change the payment system. We need payment reform in order to be able to accomplish the goals that we really want to accomplish. And that's being able to provide high quality care. That is, you know, truly, and to be able to use our teams to the utmost advantage. And so that's one thing that we really need to work on if we're going to accomplish what we really need to accomplish.
I want to echo that, and we really need to move. And it's not just APPs and other clinicians, but it's about RN care managers, it's about clinical pharmacists, it's about community health workers, integrated in the context of the clinic and working closely. But all those things are when we get payment for the team, not for the clinicians. And I think those are the kinds of changes that we need to promote, but we can't promote it if there's not a single concentrated effort to make this common good available to others. To the extent that it's diffused and it's depending on the health system, depending on how you negotiate with the powers that be, it continues to be an uphill struggle and a very frustrating struggle. To the extent that we can change and in some cases in our situation, we're having many more value-based contracts, and that gives us some flexibility. But it is an ongoing effort.
Claire, real briefly, could I just speak to the education piece? One of the really important resources out there is the Center to Advance Palliative Care and all their learning modules that one can access. Honestly, we pay for that through my institution, so I'm not sure how to get to it as an individual person out in the community. There are many different web-based teaching. There are Vital Talk and Pally Talk to learn some of the communication techniques. But those really need to be practiced in a forum where you can be coached. But I do shine the light on CAPC, C-A-P-C, as a wonderful resource for palliative care education.
And the AAFP also has resources on hospice and palliative medicine. So there are resources out there.
Thank you so much to both of you. I see Phil has joined us and we are at 1:30. So I think that's my cue to hand over. There are many other questions. I know that, and it sounds like the questions will go away, but potentially some of them could be answered by panelists now if you get a second to type in any responses you wish to.
Excellent. Well, thank you, Claire. I want to have to thank you for all of your work. And I want to thank all of our presenters and panelists. That was a perfect way to open the workshop. I think it sets a foundation for discussion. There'll be threads that carry forth from this presentation throughout the rest of today and next week. For example, in our next session, we'll be talking about that critical team-based care that you heard from all of our panelists, its role, and then Doctors Stewart and Hyan both emphasized the importance of value-based payment. That will kick off, that will be a key focus of our first session next week. So thank you all for getting us started in exactly the right direction. So we will transition next to our second session of the day, which explores the role of interdisciplinary teams in caring for people with serious illness in primary care settings. To moderate this discussion. We are thrilled to have Lori Bishop with us. Lori is Vice President of Palliative and Advanced Care for the National Hospice and Palliative Care Organization. Also has important clinical experience as a longtime nurse and also working in innovative advanced care programs that I'm sure will be invaluable in her moderating discussion after our excellent slate of presenters share their expertise with us in session 2. So I will hand things over to Lori.
Thank you so much, Phil. It is such an honor to be here with everyone. And I'm going to do brief introductions of our speakers for this focused session on interdisciplinary care and how we integrate that into primary care. And you can find full bios for our speakers in the briefing book on the event webpage. First of all, we're going to hear from Marianne Logan Fingerhood, who is the track coordinator of Adult Gerontological Nurse Practitioner Program and the SNAPT Nurse Practitioner Fellowship Program Director and an assistant professor at Johns Hopkins School of Nursing. Marianne's going to speak to innovative approaches for high-risk patients, specifically sharing information about the SHARP team. And then after Marianne, we'll hear from Karen Bullock. She is a professor and head of the School of Social Work at North Carolina State University. Karen's going to share the role of interdisciplinary teams in caring for people with serious illness in primary care settings, particularly from a social work perspective. And then we'll hear from Greg Vanderkief, who is the medical director for the Palliative Care Practice Group at Providence Institute for Human Caring and palliative care physician and clinical ethicist for Providence St. Peter Hospital. He will focus on integrating serious illness care into primary care delivery. And I hope he's also going to talk a little bit about Project Echo that Martha planted the seed for in the first session. And then Danetta Sloan is the assistant scientist at Johns Hopkins University Bloomberg School of Public Health, and she'll be providing some information on research regarding advanced care planning, shared decision-making tools for non-cancer chronic serious illness, which again was a topic that was brought up in the other session. And finally, last but not least, Russell Phillips, the director at the Center for Primary Care at Harvard Medical School, will speak about the integration of palliative care and primary care, which we did get some questions about in the previous session. I just want to welcome this esteemed group of panelists and experts, and I'm going to turn it over to Marianne. And just a reminder, you each have 10 minutes. Thank you.
Good afternoon, everyone. I am Marianne Fingerhood. I bring to you not only some expertise as a frontline clinician, but also as an educator. They were speaking a little bit about, how do we educate people about this? And this looking at team-based care is definitely something at the School of Nursing that we are very interested in moving forward. So the next slide, please. So when we were looking at our group of patients with serious illnesses, we saw that there was really a problem as we were not integrating care very well. So we were looking at the fact that we had an increasing amount of patients with serious illness. We were seeing a certain increase in hospitalizations of those patients, more and more office visits to their primary care providers, which was increasing cost. We wanted to increase the accountability of the patients that we were seeing, accountability both to the patient and their families, big things about coordination of care. And in the last year, all of us have seen a significant increase in the amount of use of telemedicine. And part of what we rolled into this program was the use of telemedicine. The next slide. So what is SHARP? SHARP stands for Small, High Acuity, and Risk Panel. It was set up because we wanted to be able to give some additional care to those patients that had, that were, much more serious illness. So it was very, very important that we got together the right group of providers to make sure that we were taking really good care of these patients. The next slide. So who did we gather into the SHARP team? The teams were actually led by nurse practitioners. Actually, many of our graduates from the Hopkins School of Nursing became our SHARP providers. They worked very closely with primary care providers. The primary care providers in our office were both physicians and nurse practitioners. We had an RN that helped support the team. She served as a triage nurse as well as someone who did a lot of follow-up for us. We had a pharmacist that worked with us. As most of us who work with really complicated patients, polypharmacy is a big concern. We also found that, we've come to the end of the rainbow on the medications for some of these patients. And our pharmacists helped us really change around the regimens for these patients and actually increase their quality of life. We have social work that works with us not only from a mental health standpoint, but also with helping with some of those disparities and helping our patients get the support that they need. We work with a specific home care group. The home care group actually works very closely with the SHARP nurse practitioner, where they will see the patient in the home, especially directly after discharge from the hospital, and they will actually be able to coordinate care very well. We have a physical therapy group that works with us. Not only are they seeing patients in an outpatient physical therapy, but we also have the ability to have them go in and take care of patients within the home. We also work with an occupational therapist who does an amazing job with helping patients really start to increase their ability to care for themselves. They also work very closely with their families. We have a palliative and hospice care group that we work with very closely. When we look at the type of patients that we are caring for, of course, we're looking at patients with cancer, but we're also looking with people with other significant serious illnesses. Can you take the next slide? So what types of our patients did we identify as being high risk? Some of the social factors, where the patients are living, how much access do they have to healthy food? How much support do they have from family members? These patients have multiple comorbidities. They're just not your run-of-the-mill patient with high blood pressure who happens to be 80 or 90. These people have end-stage COPD, they have congestive heart failure, they are brittle diabetics. So many, many patients with chronic but very complicated. We also were seeing a lot of patients with multiple hospital admissions. Our aim is to be able to care for patients in their homes and in the community rather than multiple hospitalizations. Can you go next slide? So how do we recruit the patients that we're using the SHARP program for? We get a report of hospitalizations. So we were looking at those patients who were admitted more than once in a 6-month period of time. We also looked at those patients that were a higher utilization of resources, and of course, those frequent office visits. We also looked at HEDIS measures and how many of our patients were really poorly controlled. Were we not meeting goals for hypertension? Were we not meeting goals for patients with hemoglobin A1Cs for diabetics? And then one of the more important things, we were looking at the appropriateness of our end-of-life planning. These patients were very ill. Were we helping the patient and their family make those decisions that will promote a smooth transition at the end of life? One more. So we were looking at what was the role of the primary care provider. It was these patients already had an established relationship with their primary care providers. And most of the time that primary care provider had already determined the needs that the individual patient might need. So when they went to collaborate with the SHARP team, they already had a decent idea of what the patient needed and those people that needed to be integrated in the care. For those of us who do primary care, I love the fact that someone gets an hour to take care of patients. Our SNAP NPs do, but our SHARP NPs do, but as a primary care provider, I get 15 to 30 minutes at the maximum to care for my patients. So I can make the initial plan, but in many cases, my SHARP NP can see a patient once a week, where I may only have the ability to get them into my schedule every month or every 3 months. So being able to collaborate that team and to be able to hand off some of those things so their patient has continuity of care has been incredibly important. The next slide. And how do we kind of work in those principles of palliative care? Huge portion of what we do with these patients is communication with the patient, communication with the family members, communication with all of the subspecialists. We want to make sure that the patient is truly the center of care and we are just helping them make sure everything works. Huge part of it is emotional care for both the patients and the families. If you've ever cared for anyone with a long-term, very serious illness, there's a lot of emotional care that goes along with it. And it really does help that they have a collaborative team there to support them. The social issues that go along with people with very serious illnesses, it's best cared for with a number of different people. And this program has actually worked very well. Patient satisfaction with this particular group has been just amazing. Teamwork is a huge part of how we have been able to adequately care for these patients. Respect and support, not only for the patient, but for the family has been a huge part of this. And the very core of it is making sure that we do adequate long-term planning for those patients. I look forward to talking to you during the panel discussion.
Thank you so much, Mary Ann. That was wonderful. And now we're going to hear from Erin Bullock.
Hello, everyone. I am Erin Bullock, and I am a clinical social worker. And I'm going to be speaking more generally about the role of social workers on teams in serious illness care, excuse me. And I'm also going to speak generally about our social work profession. Next slide. Long before COVID-19 and before the pandemic, we knew that social workers were essential workers, providing direct and indirect services to patients and families as they faced life-changing decisions. We are a profession of more than 600,000 professional social workers in the US, and we are a value-based profession. And those core values of our profession include service, social justice, dignity and worth of the person, importance of human relationships, integrity, and competence. And these values are codified in our code of ethics. Next slide. For those in the audience who may be less familiar with our code of ethics, it's important for me to emphasize that cultural competence is notably a compilation of acquired knowledge, awareness, humility, skills, and observable practice behaviors that are central to evaluating effectiveness among our teams. Next slide. In integrated primary care, there is an intersectionality between the behavioral health and the medical health services that our patients and families are seeking or may be in need of. When patients are seeking interventions or help or care for a physical health condition, they are often also dealing with psychosocial needs, and these may accompany and be intertwined with the health condition that they're presenting with. And so we as social workers must assess for this intersectionality. And Dr. Twaddle, I greatly appreciate your emphasis on the role of social workers on your team. And from there, I would like to emphasize this role of advocacy that we play, which oftentimes, thank you for the next slide, which oftentimes may not be as visible when your team is operating for some as it may be for others. But social workers play a critical role in advocacy, and it's actually one of the cornerstones of the work that we do. We champion the rights of individuals and communities with the goal of achieving equity. And there's a concept that I often use in my work, and I'd like to just speak just briefly and generally about it, and it's distributive justice. So distributive justice is a concept that's really important for us to consider in interdisciplinary care and integrated care and serious illness care, because it really helps us to think about and reimagine this notion of counterbalancing wealth and power in the allocation of healthcare resources and services, which can create the means for eliminating disparities. Next slide. Professionally trained social workers focus on the comprehensive factors that affect health and wellness. Serious illness care for us as social workers include treatment planning, coordination of care, administration of services, and a whole host of other skills and sets of behaviors that we must incorporate into our practice in order to address the needs of relieving suffering for our patients who are faced with serious illnesses. The psychological, emotional, social, and spiritual support, as well as the behavioral approaches to pain management and other psychosocial services are within the domain of our treatment and our interventions and the perspective that we take in order to assist and support patients and families. Next slide. And this occurs in what I like to refer to as a relationship context, and that context is the patient system, and then there's the practitioner system, and those get integrated in the most optimal ways in providing care. And so we must take into consideration what the patient was experiencing before they entered into the care system, or before some of you may be providing care in the community or in the homes. And we need to contextualize our care. I really appreciate Ms. Robeson's comments about your experience and the way in which there was a lack of co-creating this experience, because oftentimes the patients that I work with or hear from or engage in my research are experiencing something very similar to what you described, unfortunately. And I had my own personal experiences with my mother when she was diagnosed with metastatic lung cancer and was entering into a system of care that wasn't aligned with her values. So there wasn't goal concordant care. And so I have an appreciation for many, if not all, of the discussions that we've begun today. And I think it's helping us to really think about this relational context, the relationship context in which patient care is co-created. Next slide. And so how might these services, serious illness care services, be provided with the social worker sort of at the core of this? Perhaps the care is delivered in hospice care center or through an in-home care service. With hospice social workers in particular, we receive specialized training and education to provide these services in community-based care settings, and also may follow up with patients who need intensive medical care during hospital visits and a host of other services. I think specifically about a hospice care center here in Raleigh, North Carolina, with my colleague, Dr. Christine Condelwall and her team, who is developing a practicum for integrated training, interdisciplinary training that would include a host of various disciplines, medicine, nursing, social work, pastoral care, etc. And we are now focusing more intentionally on ways that we can integrate this care in what we perceive or what has been thought to be primary care settings in the absence of some of this very critical and essential support that patients need when they are faced with serious illness. Next slide. The palliative care social worker also may conduct home visits and assist and support families in their homes. And they may oftentimes in this advocacy role work very closely with the medical providers to carry out the care. But as was alluded to again by Dr. Twaddle earlier, is that patients have this experience with the illness that we as the provider, as the clinician, do not have. And so it's really critical for us to use our training and education to do what we often refer to in social work is start where the patient is and understand what was this experience like before they entered into this care system. And so social workers do receive specialized training as well. Some people think that we don't, but we do. There's specialized training and education that's competency-based, and it's critical for ensuring that all patients and families receive optimal care. And to do that deep dive that Dr. Twaddle referred to earlier, that may start with an assessment, but go well beyond that assessment. And if anyone's interested in knowing more about this specialized training and education, the certification of competencies that I'm referring to, there is an organization, it's the Association of Palliative and Hospice Social Worker Certification. And right now, the application process is open. This may be new information to someone in the audience, so I want to make sure that I emphasize it. Next slide, please. Social workers have a critical role as members of primary care teams with patients living with serious illness. There's difference in the role that the social worker has on the team, and several of the presenters today have already alluded to that. Starting with perhaps the assessment, but from assessment to treatment planning, to reevaluation, care coordination, even ensuring goal concordant care, and addressing structural racism and health equity. So we do a lot on our teams, and sometimes it may be silent in some ways, meaning that the emphasis on the work that we are doing, if we're effective, may not stand out as a part of the team, and that's fine, as long as we're all working in concert for the best care that we can provide, and that best is determined by the patient and the families. And there is a need to assess for challenges that may emerge both on the team, but also challenges perhaps in what the patient may prefer. Culturally based, culturally congruent care sometimes can be a challenge, and social workers are especially equipped to help the teams to think about ways that we can assess for these challenges, and we must be familiar with the resources that are available both within the primary care setting and outside of the primary care setting in order to provide equitable care. Next slide. And thus that leads me to the point of leadership in social work, because we need leaders. We must engage in leadership to bring about these changes, and leadership in integrated primary care settings are essential. Promoting social workers into leadership roles can be key because we play a critical role in helping our teams to develop competencies and action steps towards eliminating disparities and addressing disparities. As a value-based profession, we are trained and equipped with knowledge and competencies to help our teams develop policies and practices that address long-standing systemic health and social inequities. And in closing, I would like to emphasize that, again, the COVID-19 pandemic has really shed light on the essential role of social workers, and our perspective of distributive justice is one that can be very useful as guiding frameworks for identifying structural barriers to not only hospice and palliative care, but serious illness care in general for many Black and Brown people, especially, who continue to be at risk for greater morbidity and mortality. And so as team members, social workers are equipped to help you create opportunities and access to address greater health equity and serious illness care. Thank you.
Thank you so much, Karen. That was wonderful. And as the mother of a hospice social worker, you did your profession proud.
Thank you.
I'd like to turn it over now to Greg Vanderkief.
Thank you, Lori, and I appreciate the opportunity to be a part of this session today, so thank you for the invitation. My name is Greg Vanderkief, and I work with the Providence Health System, and for context, that's a large West Coast health system. We serve 7 states with over 50 hospitals and almost 1,100 clinics, so a fairly large basis. Next slide, please. I'm going to talk about 3 different projects today. The first is the Washington Rural Palliative Care Initiative. The second one, which Lori will be happy to hear, is about Project ECHO. And the third will be to focus in on work done by the Providence, Oregon region to integrate primary palliative care training into primary care and relevant subspecialty clinics. Starting with the Washington Rural Palliative Care Initiative, this is an initiative that was begun in early 2017, led by the director of the Washington Department of Health's Office of Rural Health. It's a public-private partnership of over 24 organizations, funded largely by Cambia, supported by Stratus Health, funding from Amerigroup and Anthem, as well as the Federal Office of Rural Health Policy and HRSA, and then multiple sources of in-kind contributions. This is built very much on work that Stratus Health, a quality improvement organization based in Minnesota, had done previously. In 2009, they began work on rural palliative care, and they've built up now to where they have 23 different rural Minnesota communities are offering some form of palliative care services. They eventually spun off another project involving North Dakota, Wisconsin, and Washington, which led to the development of the Washington Rural Palliative Care Initiative. And you can see the objectives there, which are largely very much what this workshop is about: to better provide palliative care resources to rural communities through both access to specialty resources and moving things upstream into primary palliative care. Next slide, please. This slide demonstrates the clinics that are involved. Clinics and teams. We started out in 2017 with 7 communities, and then in 2019 added 10 more, so a total of 17 rural communities. For those who aren't that familiar with Washington's geography, these communities range from waterfront communities, seagoing fisher communities, timber communities, rangeland, farmland, orchards, and retirement communities. 14 of the 17 communities remain quite active in the project. 4 of them, through things of staffing and diminished administrative support, are now more passively involved. Interestingly, focusing in on the interdisciplinary team aspect of this, our local teams have quite a variety of local leaders. 12 of the teams are led by nurses, 3 are led by physicians, and then 1 each by a nurse practitioner, a social worker, a chaplain, or a non-clinical administrator. The teams are based in critical access hospitals, federally qualified health centers, primary care practices, home health programs, and at least one is a very innovative collaboration of clinical and community-based volunteers. Cohort participants also cross the spectrum of disciplines, nursing being the most common, physicians and social workers tied for second, nurse practitioners next, and then chaplains, pharmacists, PAs, dietitians, paramedics, nursing assistants. Next slide, please. So we have, and as I'm talking here, my phone is buzzing for an ethics consult. Great timing. So this model here, we start at the 10 o'clock position, community education and engagement. The Department of Health's Office of Rural Health team went out and did in-person site visits to the 7 cohort 1 communities, and we're doing the same thing through the 10 cohort 2 communities when the pandemic hit. And so many of the site visits have become virtual instead. The site visits are intended to do relationship and team building, education to clinicians and community members, as well as an in-depth community asset and gap analysis. And they go quite deep into what are the resources that are available, what are the community needs, and how can we help bridge the difference, going back to Phil's original slide with the bridges. In mid-2018, this next oval at about the 7 o'clock position, we started doing telehealth case consultations. It's not quite Project ECHO, but it was based on a similar model. But what it is, instead of having a didactic, is purely case consultations. The cohort teams will bring cases to a specialized palliative care team that beams in via Zoom. And so the local teams, again, are primarily primary care based. Some of them do have some additional specialty palliative care training, but for the most part, they come from a primary care background. And then they have the input of a specialized palliative care physician, nurse practitioner, social worker, chaplain, and nurse to do real-time telehealth case consultations. We're not doing direct-to-patient consults yet, although there is some work afoot. This is mainly a supportive case consultation model. And then at the end of these sessions, our nurse coordinator for the project will put together a detailed summary of discussion points and recommendations and send it back to the community to help give them guidance. And this occurred twice a month during the initial cohort 1 phase and eventually moved on to monthly as we moved into cohort 2. A couple of other projects that are evolving out of this: direct-to-patient telemedicine. At least 3 cohort teams are doing that at this point. Some are doing it via essentially virtual visits. Others are having on-site palliative care or other social workers, nurse, chaplains at the site who would then beam in a specialized palliative care physician or social worker to complete the interdisciplinary team and do full spectrum palliative care consults with a blended in-person on-site model with telehealth. What are our outcomes? The detailed data is still pending, but they did a 6-month look back at people who were involved in the project, who were cared for, so the patients involved, and compared ER utilization, hospitalization, length of hospital stay, rate of hospice referrals, things of that sort. And what they found is looking back 6 months prior to enrollment compared to the period after enrollment was a dramatic reduction in particularly ER utilization and hospitalization, as well as diminished length of stay. Another outcome that's harder to measure, but we've heard very clearly about this from our participants, is the value of community. That is, what sense do they have of being a part of a broader community and not being all alone in their rural setting? Next slide, please. Next up, Project ECHO HPM Cares. The HPM Cares stands for Hospice and Palliative Medicine COVID Action and Resilience Education Support. Project ECHO, which ECHO is Extension for Community Healthcare Outcomes, is a perfect model of extending serious illness care into the primary care setting. It first developed to help specialized hepatology for hepatitis C care go out of the tertiary care center in Albuquerque, New Mexico, into rural New Mexico communities to help primary care providers serve their patients who had difficulty getting in for subspecialty tertiary or quaternary care level care. And what they found is the people who participated in this tele-model, really a tele-mentoring model more than telehealth model, were able to improve overall outcomes because it improved the primary care clinicians in the community's ability to meet their hepatitis C patients' needs. And the specialists in Albuquerque learned more about what care is like in the rural communities. And so there was a distinct improvement in outcomes. Currently, ECHO has over 400 hubs for more than 100 diseases in 44 countries. And it is a blend of case consultations, mini models. People present cases in real time for feedback to directly impact care. And other times, the cases are more academic only. Next slide, please. Our Project ECHO series has had people participate from 34 different states. We've had 100 sessions. 1-year anniversary was June 5. The only Thursdays we've missed since then were Thanksgiving and New Year's Eve. We've had 852 unique attendees. 5% of the participants have joined in for over 10 sessions. 144 have attended both a hospice and a palliative care session. We divided it into palliative care and hospice cohorts. So every other week, the hospice cohort meets, and then on the alternate week, every other week, the palliative care cohort meets. And some people participate in both because they're serving in both settings. The other thing I would add is there are 2 hubs. This was originated by Four Seasons Compassion for Life out of North Carolina. And then we at Providence were invited to join in to broaden it. But then with the pandemic, we went from doing general outreach to specifically COVID-related outreach. The initial project, and I see Lori's popping up that my time is warning me. Okay, the initial project was targeting rural primary care providers as well as community-based palliative care nurse practitioners to try and really do outreach in the community. Next slide, please. Experience so far, there's a moral distress survey that we still have a lot of work we need to do to fully reconcile what that is telling us, but reading through the narratives of the moral distress that are experienced in the settings is quite powerful. Again, building community, and then the 3 bullet points at the bottom are all around team building. 95% of people feel like they are better able to work in an interdisciplinary team, 92% feel more motivated to communicate, and then 92% also feel like they have higher skill level to work with a team. Next slide, please. The final initiative is a project by the Providence Medical Group in the Oregon region to develop primary palliative care training throughout the medical group within Oregon. There are over 50 primary care clinics and 150 subspecialty clinics. The initiative came from the Providence Medical Group leader who said, could we have a palliative care person in every clinic? And when they did the math, that was just not feasible. So they decided to take a population health model, figure out how to create specialty or to training for primary palliative care. Next slide, please. And in doing so, there's a foundational level of care where every clinic person in a primary care clinic will undergo some vital talk training and on-site in-service type training. Intermediate level of training, people will go through 4 weeks of specialized training over the course of the year, and hopefully then be able to be the trainers for the foundational level. Advanced training, they want to have at least one advanced certified person who went through the University of Washington certificate program in palliative care in each clinic, and then the specialized palliative care teams would be there to support them. Next slide, please. In the early stages, they've looked at what are the impacts, and the two circled lines demonstrate that compared to baseline, a nearly 7% increase in advanced directive completion in the primary care practices, and a nearly 15% increase in a specific type of goals of care note in the primary care practices that have gone through this. So substantial change from baseline by the specialized palliative care training. And with that, Lori, I will just summarize by saying these are three very different initiatives. The key focus in all three is engagement and training for all members of the interdisciplinary team, and each has had a focus in trying to move things deeper into the primary care setting before having to turn to specialty palliative care. Thank you, Lori.
Thank you so much, Greg. What great work and great example of a variety of initiatives to try and get the job done. Now we're going to hear from Danetta Sloan. Take it away, Danetta.
Hi, good afternoon, and thank you so much to the Academy for inviting me to present. I'll be talking to you today about advanced care planning shared decision-making tools for non-cancer chronic serious illness, a mixed methods study, and I do recognize that some of this was covered before. However, I wanted to talk about this because I feel that I am a social worker, a hospice social worker, and I feel it is important to our field and to the interdisciplinary team. Often the social worker in hospice is the one that is called in to have conversations with the patients and the families about advanced care planning. And there is a very delicate balance between our values of meeting the patients where they are and focusing on patient-centered conversations and meeting the institutional needs, walk in with the advanced directive and said, and be told to quickly, this has to be completed and placed in the chart. So I wanted to discuss exactly what we can do to address some of these instances. Next slide, please. So this project is an overall systematic review that was funded by the Agency for Healthcare Research and Quality to the Johns Hopkins Evidence-Based Practice Center. It was part of a larger systematic review, mixed methods review, really integrating palliative care with chronic disease management and ambulatory care. We followed the methods outlined in the Agency for Healthcare Research and Quality methods guides for effective and comparative effectiveness reviews. Next slide, please. So the overarching objectives and key questions really was to evaluate the effectiveness and the implementation of interventions for integrating palliative care in ambulatory care for adults with serious life-threatening illnesses and their caregivers. And I want to say up front that this was an exclusion of those diagnosed with cancer. So we evaluated interventions addressing identification of patients and patient and caregiver education, shared decision-making tools, clinician education, and models of care overall. Today, I'm going to be talking to you about shared decision-making tools, however. And there were three overarching key questions that we wanted to address as a part of each category. And basically we wanted to look at what was available or what is available, what is the effectiveness, and how is it implemented. Next slide, please. Can you advance one more time? Oh, so I moved that up, but what I'm talking about is what palliative care decision-making tools are available for clinician, patients, and caregivers in ambulatory care. Next slide, please. So in talking about what is available, we recognize that studies had to meet, all of our studies had to meet the criteria of being relevant to the key questions. Could you go back one more slide? I'm sorry. To be relevant to the key questions. And these are the 5 overall key questions that we looked at. And out of 384 full text articles for shared decision-making tools, we only found 11 studies that actually met the criteria, and 6 were quantitative and 5 were qualitative. Next slide now. All the shared decision-making tools, I will say, address goals of care communication and advanced care planning. So with the first 6, which answered the question, what is the effectiveness of palliative care shared decision-making tools for patients with serious life-threatening chronic illness or conditions in ambulatory settings and their caregivers, the 6 randomized controlled trials that we found included 1,567 patients and 58 caregivers. The chronic illnesses basically were renal disease, COPD, and multiple serious illnesses. And they all addressed advanced directives or goal of care communications. And the results basically was palliative care shared decision-making tools may improve patient satisfaction with communications, but the strength of evidence was low. And palliative care shared decision-making tools may increase advanced directives documentation. Again, the strength of evidence was low. And we really could not draw any conclusions about the effect of shared decision-making tools on caregiver satisfaction or patient symptoms of depression. And no studies addressed other critical outcomes. Now, I will say that often the strength of evidence was low because of the sample size. The sample sizes were low as well. Next slide, please. When we looked at implementation, there were 5 qualitative studies. The key question for the implementation was, how have palliative care shared decision-making tools been implemented for patients with serious life-threatening chronic illness or conditions in ambulatory care and their caregivers? Very long question. And what is the evidence for how, when, and for which patients and caregivers they can best be implemented in care? So the 5 qualitative studies were on advanced care planning and documentation. There are 18 patients and 38 caregivers, 21 non-palliative care ambulatory clinicians. And the chronic diseases really included COPD, renal disease, and heart failure. And the results was that patients and caregivers preferred advanced care planning discussions grounded in patient and caregivers' experiences of illnesses rather than general conversations about end of life. So this is a part of what we say in social work as meeting the patients where they are. And the next finding was patients and caregivers reported timing of advanced care planning conversations should be individualized to the specific patient and the caregiver situation at that time. And the clinicians preferred advanced care planning shared decision-making tools that were time efficient and included structured scripting. Next slide, please. So overall, the integrative synthesis for shared decision-making tools included websites, qualitative, quantitative, and key informants. So our approach to assessing what was out there and actually designing our review was to meet with our key informants, which included professionals from the field and as well as patients and caregivers, and the complete interdisciplinary team of the physician, the nurses, social workers, and chaplains to really be thoughtful about what the questions are that needed to be asked and our approach to evaluating, what was available in the field. So the summary of findings is that as far as intervention content, qualitative evidence emphasized grounding in patient and caregiver experiences of illness. And this was a key component of several of the shared decision-making tools that were evaluated for effectiveness. Also the structure, although qualitative evidence emphasized that interventions should be time efficient, specific and succinct effectiveness studies also included more lengthy interventions, and they were conducted by additional staff outside of the routine flow. And so that's a direct challenge to integrating these models, the shared decision-making models, into ambulatory care. And so we have to think about the implementation piece of timing and the preferences. And also the eligible patients, or what are the triggers? When should these discussions become apparent, and when are they needed? Next slide, please. Next slide, please. Thank you. And so I just want to point out under the research, and you can read this for yourself, but I'm a social work scientist. And so we must think about when we're developing our models, how it's going to impact the interdisciplinary team as well as our patients. What we did find is none of the studies that we were able to abstract included any, they weren't diverse, and they didn't include any assessments of health equity or talk about disparities at all. The samples weren't diverse at all. And so future investigations really need to think about culturally appropriate ways of developing and testing interventions that meet the needs of all of the patients that we are serving. Next slide, please, and the last one. I just wanted to bring up how we can do this, and some of my work is in partnering with the community organizations, really the Black church. In the study, I just wanted to put this out here, is that when we are doing our research, we have to think about partnering. In this study, I actually asked church members, parishioners, if they were interested. 5 questions. Are you interested? Are you caring for someone or have ever cared for someone with a chronic illness or life-threatening illness? And or at end of life? And is end of life care important to you? And have you talked to someone who will make a decision for you if you can't make one for yourself? And would you like more information? Overwhelmingly, we found that 93% of the people that we surveyed wanted more information. And I have to say that this study was done in a Black church over a weekend, a 2-day period. 930 people responded to the survey saying, yes, we need more information. We want more information. And some of my more recent work, people are saying, you go to the doctor's office, there's all kinds of information, but there's nothing about end-of-life care or advanced care planning. And so I implore you, as we are developing our models and testing our models, to partner with the community and people in the community so that we can understand the needs of the people that we are serving and develop culturally appropriate models to integrate into our practice and integrate into training our interdisciplinary teams who provide this care. Thank you.
Thank you so much, Danetta. And I know we don't have a chaplain represented on our interdisciplinary team here. So maybe we can discuss a little bit more of the role of the chaplain and maybe engaging with some of those faith-based leaders to build that relationship when we get to the Q&A. Now I'd like to bring out Dr. Phillips and let him take it away.
Okay, thank you very much. Next slide, please. So first I want to say that this has been a wonderful session. I've really learned a lot and enjoyed hearing about how others are thinking about palliative care and primary care. And clearly the point has been made that palliative care is a team sport, just like primary care is. And what I'll talk about is a little bit about how we create the team of primary care that enables us to care for patients in the best possible way. I want to talk a little bit about my own experience, and then I'll talk a little bit about the shared models for primary care, how those apply to chronic care, and then how we might use the collaborative care model for depression and apply that to the instance of patients with palliative care. First, I should say that before I became director of the Center for Primary Care, I was division chief in general medicine and had the opportunities to create interventions within our hospital-based practice where I see patients. And one of the things that we tried to do is we tried to improve palliative care in the practice was to insert a palliative care specialist into the practice. And what was surprising to me is that there was very little use of that palliative care specialist. And reasons were, I think, that first, that primary care physicians did not want to give up the responsibility to care for patients with serious illness. And in addition, we didn't really surround them by a system that supported their work. I have a panel myself that numbers about 250 patients. I see patients between a half day and a day a week, and I've done that consistently for 40 years. In preparation for this talk, I looked at both the total number of patients I've cared for as well as the number that have died since I've been a primary care physician. And the total number, although my panel usually numbers 250, I've cared for 700 patients, as I've certainly lost some to attrition due to death, to moving away, to choosing another physician. But what's actually surprising to me is that I've had 100 patients die during that time, which means that 1 in 7 of my patients have passed away, which I think is perhaps higher than most primary care practices, because I practice in a hospital-based practice where we take care of a lot of patients with fairly severe chronic illness. But I don't think it's out of the range of what many primary care physicians might see, especially when they're working in a community with patients with complex care needs. I'd also say that losing a patient to death from severe illness then is a common experience in primary care. And in terms of prevalence, if it really is 1 in 7, it's very similar in prevalence to diabetes or to depression, which are two things that we certainly feel strongly about being able to manage within our comprehensive care of patients in a primary care practice. Next slide, please. Just to review, I wanted to go over the principles of chronic or severe illness care. And these are very aligned, if not drawn from the 7 principles that have been developed by the Patient-Centered Primary Care Collaborative, or the PCC. First, that chronic and severe illness care should be patient, family, community-centered, in the sense that we reach beyond our patients and families and engage community organizations. In the case of severe illness, often hospices. Care is continuous, it's relationship-based. That relationship is so important to patients, especially near end of life. We provide comprehensive and equitable care for all, from first contact, and I added to end of life. I think, again, that's an incredibly important time, as we've all discussed. It's a team-based collaborative effort that's inclusive of social workers, nurses, clergy, a variety of those who we talked about today, of those interprofessions. It's coordinated and integrated with open channels of communication between both primary care physicians, members of the primary care team, as well as specialist teams. Accessible 24/7 coverage is key. I don't expect everyone to do this, but for my patients who are near end of life or who are on hospice, I provide my cell phone so that I'm immediately accessible to patients. And then finally, care is meant to be high value. And end of life, this also means trying to figure out how we can extend quality time for patients, how we can prevent unwanted services. This may include hospitalizations or certainly ICU stays. And that's especially true at the end of life. Next slide, please. And the collaborative care model is a model that we've done a lot of work on, and certainly there's an incredibly strong evidence base for. The impact study showed how important it can be for patients with depression, and it's shown to not only reduce costs of care, but to improve symptoms and to actually be life-saving in the sense of prevention of mortality due to suicide. And the critical components of it are there are patients, there's a patient-centered care team. In the case of, as we sort of think about how it would apply to palliative care, there would be a primary care physician involved, an advanced practice nurse or physician's assistant with expertise in end-of-life care, a population health manager who would help track patients over time, as well as a medical assistant who would help identify symptoms and screen patients for entry into what might be a database or registry by which we would follow patients. The first step, as in identifying patients with depression, would be to identify patients with serious illness. And there are a variety of ways to do this. And most often this is done by physicians using questions like the surprise question, asking yourself whether you'd be surprised if your patient passed away before or died within the next year. That's been shown to be a risk factor for mortality, although probably doesn't have adequate sensitivity as a screening test in itself. But there are also excellent prognostic indexes that could be applied either to every information in the clinical record or to billing data. We could create registries for patients with severe chronic illness that can be followed by our population managers. We can have discussions with the primary care physicians or advanced practice nurses on preferences for care, on who the healthcare proxy is or would be in the event the patient's unable to speak for themselves, and preferences for site of care at death, home versus hospital, as well as begin to explore the meaning of hospice and whether that's something that patients will be open to and what they see as the advantages and disadvantages of being in hospice. To monitor symptoms over time, often the medical assistant might do that and identify poorly controlled symptoms that might include depression and substance use, and then intervene as needed, whether it be with diagnostic tests, treatments, and referrals. Again, in depression, that might be to psychiatry. For palliative care, that would be hopefully to a palliative care specialist that we have access to either through telemedicine or because our system provides one, and then tracking response to interventions. And then there'd be continuous and regular visits with the primary care physician, potentially the advanced practice nurse and the physician's assistant, and even do that when somebody's in hospice as well. Again, in my case, I like to be the physician of record when somebody's in hospice, but I don't think that's always required. But I think engagement at that time is especially important. Again, myself like to try to visit patients at home, especially when they're no longer mobile, when they're on hospice. So there's a clear sort of connection at what is a critical time, both for patients and their families. Next slide, please. There are a number of barriers and facilitators to this model. One is payment, because a number of these things that I've referred to are not currently supported. A population manager is supported in the case of the collaborative care model for depression, but for this purpose, I don't think would be. Clearly there are additional resources that are needed within primary care practices, access to clergy, social workers to coordinate care, And, those are things that need to be supported. There are chronic care management fees and other payments that potentially one might have access to. Quality metrics, severity adjustment, incentives to serve as hospice care physician of record. I think all of those are important in thinking about payment. I myself and in the center, we believe strongly in the importance of prospective payment or capitation. And in the case of the chronic care model for depression, are looking at the cost of that to practices. So it could be included within a bundle that's provided to practices as part of a capitated fee that's provided to practices. And there seems like, we could do a very similar thing with patients who are receiving palliative care or support or palliative care services. By calculating the cost of those services and essentially providing a fee that would cover those costs through a capitated payment. Expertise is key. We've heard about the ECHO model as one such way to provide training. In the center, we provide learning collaboratives. We can certainly work on developing a nurse specialist role within practices. We also know that patients want care from their primary care physician at the end of life. So ways that we can learn to do this are really important. And we also know that primary care physicians desire the ability to care for patients at end of life. And I personally think that no time is more important. Next slide, please. There's several reforms that are needed in order to facilitate integrated palliative specialty care. One is that the clinician needs adequate training. We just talked about that. I think patients need more training about the benefits of palliative care. I alluded to what that means to education about hospice. For some patients, that's something that they don't know a lot about and fear, when it certainly offers lots of opportunity and benefits. The delivery system itself, we need to find ways to integrate nurses, physicians, assistants with palliative care expertise into primary care practice. We need to have relationships with hospice. One of the challenges I have is that I'm usually working with a different hospice each time I'm working with a patient who is at end of life, and creating referral guidelines for palliative care specialists. And then finally, at the policy level, developing adequate payment for care with patients with serious illness, preferably as a capitated amount, reinforcing primary care competencies among all healthcare providers, redefining palliative care as appropriate at earlier stage of illnesses than when death is imminent, because certainly the observation is that often palliative care or hospice is a near-death decision as opposed to something that could happen much earlier and therefore extend quality time at end of life. I think I'll stop there, but thanks so much. It's great to have an opportunity to be part of this discussion.
Well, thank you so much, and keep your camera on, and let's bring back our other speakers. Just wonderful presentations. I think we continued on a theme that got started in the first session about the importance of the interdisciplinary team and the team sport. I've heard a couple of times the challenge with a little bit on the reimbursement side, especially when you're engaging an interdisciplinary team. And yes, there are some opportunities for incident to billing, but doesn't always cover all that investment. I was excited, and I think I put in the Q&A an answer for one individual that there was an announcement yesterday that's now in a McKnight article today that CMMI is committed to implementing a palliative care model demonstration. So let's watch for that. I know that we at NHPCO and at the National Coalition have been pushing for a model that is in close collaboration with primary care, because we do feel that relationship is a sacred one, and how do we complement each other. So let's start with reimbursement and maybe talk about how you've made that work, and maybe where it falls short. So we consider that when we look at maybe potential models and demonstrations. Marianne, I'm going to start with you just because you really had a well thought out, sharp team there with that. I mean, your model is sharp, I'm just going to say. So maybe start there.
Something catchy.
And then we'll open up to others.
So actually the model was started through a grant from Maryland Medicare. And we were able to build the model from that. We also work with a fair amount of capitated patients. We also get some monies that come back to it. It's a very large organization that I work for. We have 40 primary care offices over Maryland, Virginia, and DC. So we're able to institute this, and we're actually finding that there's some cost savings the way that we're taking care of these patients. And again, within a capitated environment, cost savings means being able to use that money for other things.
Does anybody else want to weigh in on the reimbursement challenge?
Yeah, I will just comment, the Oregon project that I highlighted came about in large part because they have a very high percentage of value-based contracts in the Oregon marketplace. And that freed them up to be able to do this type of work in a way a traditional fee-for-service environment would not have supported. And so the payers were incentivized to try and determine how can we best meet the patient's needs pre-acute care. You know, we often talk about post-acute care, but they're really focusing from a population health mindset on pre-acute care. And in other markets within our system, that model would not work as well simply because the payment structure wouldn't work. So until we move to more value-based contracting, I think we're going to be constrained in just how widely we can promote models like the Oregon model I highlighted.
Yeah, if I could just say, you know, we do a lot of value-based contracting in my hospital, but the money does not necessarily flow to primary care in the sense that it comes to the organization and then the money is distributed according to a fee-for-service approach. We also, as mentioned in the first session, primary care only gets 5% of the total medical spend, which is much less than is really required to provide all the services that we would like to provide. And certainly when we think about adding new services like integrated palliative care, we need to find ways to increase the payment to closer to 10 to 15% of the total medical spend. And we're working towards that in Massachusetts.
Danetta or Karen, do you want to weigh in on this reimbursement question?
Well, I'll comment for social workers. I think most people who work as a part of a team kind of acknowledge that social work is value added, yet it's very challenging for us, for our services to be reimbursed in the way that other clinical services are reimbursable. And this really contributes, based on my discussions with other professionals, contributes to the lack of available social work services on teams, which are critical, and which then impact the care that the patient receives. And so I think that, excuse me, we're working towards doing a number of things that we think will sort of get others to recognize our value so that our services will be reimbursable, including this competency-based certificate of being certified, and it's competency-based, and a host of other things that we're really working hard to convince those who are have the power to determine whose services are reimbursable or not, that social work services should be and are valuable.
Danetta, anything to add?
No, I concur with Karen. Thank you.
Yeah, thank you. I'm going to mention chaplains in here too, because I know even in hospice care, what gets put on the bill for core services and the codes that are used, there are no codes currently for the chaplain. And the chaplain is a core service. And certainly sometimes at end of life, a visit from the chaplain is the most important visit, and not so much the medical, which oftentimes someone's stable, but they may have some existential angst, right, or suffering that needs to be addressed. In fact, I've had chaplain visits, visit frequency go to every day, and we were able to reduce pain medications because it was really more that existential suffering that was the issue. So I just want to bring the chaplain into the room because I think a couple of you have brought it up. And that role, and what's the challenge there beyond the fact that we can't get reimbursed to cover that resource?
I can speak to that a little bit, but not necessarily in terms of reimbursement. What I've noticed about interdisciplinary teams and institutions is that often the hospital chaplain is used to serve on the interdisciplinary team. And I think that, well, called in, but not even to serve on the disciplinary team, interdisciplinary team. So what I am noticing, especially in serious illness and those with serious illness, is that there is an existential piece that we cannot get around. And often when I would go out into the field on visits, I would go with my chaplain because I recognize my limitations and being able to address those existential, that existential piece. I think that chaplains are now, and clergy in general are now being involved in evidence-based research and to kind of show the value piece. And I think we need more of that. We need more of that so that our policymakers recognize the value of chaplaincy on that interdisciplinary team. So I try myself to pull them into my work as well, but I think that's what's missing, and that's like the initial steps to being reimbursed.
Laura, I think a huge gap in terms of spiritual care support remains between the acute care setting and hospice. How do you support chaplaincy in community-based palliative care? And typically it's going to be philanthropically provided, or you're going to have an organization that is enlightened enough and motivated enough to provide the full spectrum of interdisciplinary team. And then there's a lot of workarounds. Our clinic, when it opened in my local setting, we had foundation funding for a chaplain in the clinic setting. And when the grant ran out, we couldn't get an operational budget. She is now doing a surprising amount of virtual follow-up. She kind of talks with the clinic team, particularly the social worker who is embedded in the clinic, and then will contact people by video or telephone. And that's worked better than I would have envisioned. Now, many of them she has a relationship with from when she was in clinic, but that community-based setting is really difficult. And so what many teams end up doing is really deferring to the person's own clergy, which has tremendous value from their existential question. But there is a difference between one's own clergy and a clinically trained chaplain. And so we would really like to see that model broadened.
I really appreciate that. I worked in a rural community for a time that had a very distinct religious base to the majority of the population. And actually, it made it more difficult for individuals at end of life to have the conversation that they needed to have about some of that angst, you know, because it wasn't okay to have it. You had this faith and you were supposed to be okay with death and dying because you believed in an afterlife and so on. And so I'm not saying they couldn't have had it with their clergy, but they felt a bit of a barrier there. So very good point that it's not the same always to have the faith community that serves you be your spiritual care. Spiritual care sometimes needs that chaplain with that expertise. And there is also certification for chaplains in this space with palliative and hospice care too, as well as the other disciplines. So thanks for bringing that up. Anybody else want to weigh in before we talk about health equity? It seems like a natural transition, but I don't want to.
I just want to say, you know, another thing that we may think about is how can we train some of the clergy to be able to, and especially when it comes to hospice in the community, people are just comfortable with their own clergy, and chaplains are great. There's an integration of the clinical piece, but can we train some of the clergy so that they can continue to work with the families in the communities?
That's a great point. And do you think, Danetta, that gets us a little bit into that health equity piece as well, when that's a trusted member of your community that you would go to typically? Sometimes to have those conversations, you might receive information from them more readily than what you might from the clinical team.
I do agree. I think that is a large component. And I also want to caution At the same time, and this is why I feel that the training is needed, because I've seen conversations where advanced care planning conversations that have been started, and then the community clergy comes in, and we have to start all over again because the patient is reminded of, okay, well, there's hope. And if you have these conversations, then you don't have hope in your faith. And so that's why I think that it is important from an equitable perspective that we're able to include our clergy in the community who our patients trust, and that we invest in them so that we can find that balance and that cultural perspective that's needed.
And Lori, if I may continue with Danetta's comment in terms of, I've had clinicians ask me, well, what does inequity look like because they don't see it in the care setting. And so when I talk about the fact that perhaps this is just one example, we have a Catholic priest who comes in to provide the service. Well, what if you're not Catholic, if that's not your faith, and they have one or two clinicians who come, pastoral care persons to provide this care, then you have entire populations of patients whose needs aren't adequately being met. And oftentimes we don't think about it on that level because we think we're providing pastoral care, this spiritual support, but we know that people practice spirituality differently. And so that's one area that I think is really important when care organizations are looking at inequity. Spiritual care is one of the areas that we really need to attend to.
Thank you. Anyone else want to weigh in there or go a different direction with health equity? I know that we had a lovely discussion in one of our planning sessions, Danetta, about hospice care even, and the discrepancy between how whites were treated within the patient population and how African Americans were. And we talked about the safety issue, and I don't feel safe going in that neighborhood as sometimes being a cop-out for not providing equitable care, for example. And I've certainly witnessed that, and I know you have too. I don't know what else we want to say about that, or at least shine a light on some of those things so we can start having different conversations and resolve some of that, or what are your thoughts there? Anyone want to weigh in? Be bold, be brave.
Well, I didn't bring it up purposely because I can only really speak from a social worker perspective, but it does exist, and what I've realized that I consulted with a couple of my colleagues who are currently doing work in it, and it's in social work and hospice, and it still exists. And I feel that as organizations, hospice organizations, we have to pay attention to the inequities of diversity in our teams, who are willing to go out and who are comfortable with going out to meet the needs of a patient. And it doesn't matter where they are, they're still a patient. The services are there to support those visits when there are issues of safety with having security with you. Now, there is a level of discomfort with even with having security with you, with a policeman being with you. As a Black person, I may not be comfortable with that. However, I feel that it is the organization's responsibility to ensure equitable services to all their patients, and not just the ones in a higher socioeconomic neighborhood as opposed to another, or higher resourced neighborhood as opposed to a lower resourced neighborhood.
And if I may comment also, Danetta, even for the clinicians who are going into, as you refer to, a higher resource community, there are hospice providers, CNAs, who are very concerned about going into neighborhoods where they're perceived as a threat. And so even if they're not concerned about, the rate of crime or danger in the way that we typically think about it, going into the homes. We know the data show that the vast majority of people who are receiving hospice and palliative care are white. If we look at the data on the direct care providers, especially those who are at the level of CNAs and others who are going into the homes, they tend to be Black and brown people. And this is not the session really to drill down in that, but since it's been raised, it is an area that those of us who do work in this area, whether you're a researcher or a clinician, to be thinking about the quality of life for those individuals who are going into those communities where they're perceived to be a threat and the danger of even knocking on someone's door and being perceived as dangerous or threatening. And to be in those homes is really uncomfortable for those clinicians, but they need their jobs. And there's insufficient training to help people to feel comfortable going into the homes of individuals to provide care. And so anyway, that's, I guess, for another time.
Okay, we've got another roundtable topic, I think, in the making, but I think it's really important that we have that lens and think about that lens. I know we've got some questions and a lot of comments in the Q&A, and I know one that was earlier, but I think this group would be well to address is mental health, behavioral health, and the connections to mental health and behavioral health. And I wonder if you could speak a little bit to how do you partner and collaborate when that is a need that is identified? Does anybody want to start?
Well, I'm trying not to monopolize any conversation. There are many different views and perspectives, as Danetta has alluded to, but I can say from a clinical social work perspective, as I said during my presentation, is that many patients, if not most, who are coming in or who are receiving care for a physical condition will also have some psychosocial behavioral health issues, whether it's anxiety or depression, the changes in one's functional ability when they are living with a non-curable illness or they begin to decline in their functional ability. There's oftentimes some behavioral health or mental health conditions that will emerge. And it, also it could be the result of certain medications that could change the way in which one is able to function or their emotional stability, et cetera. So I think that it's important to always assess for those conditions. And if you're not the clinician who can do that assessment, social workers are well equipped to do those assessments, as we heard Dr. Throttle say earlier. So I think it is important to always be assessing for mental health, behavioral health with a patient who is experiencing or living with serious illness.
Can I just add from a scientist perspective that when we're assessing and if we're using tools to assess, that we make sure that whatever assessments we are using are validated in people that look like the people that you are providing care to. Case in point, that if we're going to measure or look at someone's distress, and I always feel that narrative assessments give you far more information than a quantitative assessment. However, sometimes I know that that is the place that we start in this medical healthcare system. But if we are trying to use something like a distress thermometer to assess someone's level of distress, especially in the community, and you have a family or family member that's used to actually their baseline is a 5, or their baseline can be a 10, our assessments cannot adequately determine what or meet the needs of the information that we are looking to meet the needs of the patients and the families that we're providing care for. So we have to be careful of that. And I know that's another, assessment tools is another
topic. Oh, we're making a list. Greg?
If I think about the theme of this workshop, integrating serious illness care into primary care delivery, I come back to the patient-centered medical home. And when that model is followed as it's intended, behavioral health is a central component of it. And it's recognizing that not even waiting for serious illness care or palliative care, but acknowledging mental health and behavioral health is a crucial part of holistic primary care. And so I think the more we can design primary care systems that incorporate that from the get-go, the more it can be integrated throughout the full continuum.
and having it more available to our patients. I think most of us as primary care providers recognize the needs, but I know in my practice and the practices in my organization, just being able to get access to behavioral health providers has been unbelievably difficult. So talk to your friends and family. They need to go out and become behavioral health.
I agree with both those comments because, in fact, many primary care practices follow the collaborative care model, which doesn't necessarily require that you have social workers and psychiatrists embedded in the practice. And the behaviorist model actually is hard for practices to afford because of payment for social workers or psychiatrists. So often are relying on community resources, and for many times those resources just don't exist, or providers don't take insurance, so that patients really have limited access to them.
I'd like to add, I've seen patients that have insurance for physical health conditions, but they don't have a behavioral health or mental health component. And it's extremely expensive to add that to their plan. So that's another barrier.
Mm-hmm.
Kind of ironic, isn't it? That's hard to get whole person care when you don't have whole person insurance coverage. We kind of touched on workforce shortage. I know we have just a few more minutes, but and telehealth certainly seems to be one tool that can help us. And this collaboration between primary care and palliative care is another way to kind of stem some of that workforce shortage. One of my concerns always is, are we competing as we expand teams within primary care and palliative care to be interdisciplinary, which is absolutely what we want? Are we robbing Peter to pay Paul? How do we stem the workforce shortage and work more collaboratively together in teams and expand our sense of team to meet that need? Anybody have any thoughts on the workforce shortage?
Well, I might loop back to the Oregon model that I talked about, where it was easily recognized or early recognized that trying to embed specialized palliative care people in all the primary care clinics would have required so much staff resources that it was just not feasible. And so they flipped the question from what do we need to do to staff up to how do we meet the needs? Well, first off, what are the community needs? And then how do we meet them? Really taking a sincere population health model. And that was what led them to, it's actually not competition, but augmentation or complementary to train people in primary care clinics to have higher level of palliative care skills. I mean, I really believe that the more people are trained up to provide high quality, serious illness care, palliative care in primary care settings or relevant subspecialties, pulmonology, oncology, cardiology, and we reserve the referrals to the specialists for the most complex cases, at least on the palliative care side, that's going to both address the workforce issues we're facing, but more importantly, from a population health mindset, it's going to be a more efficient and more effective way to meet people's needs. But it takes commitment and investment by the organizations to do so. And again, in a value-based contracting model, that's going to be much more prevalent than if we remain in our piecemeal fee-for-service model that so many people are still stuck in.
Yeah, a related model is the one referred to as e-consult, where you can consult with specialists virtually, and that can happen either through sending information over the web or through now telephone or any kind of virtual conversation. Unfortunately, as Greg has talked about, that's not really covered under a fee-for-service model. So it's another reason to move to value-based or capitated payment to cover those kinds of resources. But those have been shown to be cost saving in that you don't actually need as many specialists. In the case of palliative care, those specialists just don't really even exist. So making sure that we're using them as efficiently as possible, I think, is really critical, and e-consults offers a way forward.
I know we're at time. I just want to thank you all. It's been just a privilege to have this conversation with you, and thank you so much for sharing your expertise. And I want to turn it over. I believe I need to turn it over to Trish. Are you there, Trish?
Yes, I'm here. What a fabulous session it's been. We've really got to talk a lot about some of the really critical issues in taking care of people with serious illness in primary care. We've heard a lot about communication, planning, teamwork, person-centered care. And I loved Karen Bullock's comments about co-creating care. We've also seen some models that are working in practice. So we've got lots to think about. And so just as we close, I want to thank all of the workshop participants, the moderators and attendees, and also importantly, the NASM staff. What is great is that notes and videos of today's webinar will be archived online. And so this will be a really valuable resource for us to reflect and plan moving forward. I also really want to encourage everyone to register for the second webinar, which will be held next week on the 17th of June. And I just also, on behalf of Phil Rogers, my co-chair, just thank everybody for being part of this really critical conversation. Thanks so much. And it's been great to see so many people online watching this. And for the people that couldn't come, please make sure that they know that they can have access to the recording. So thank you so much, everybody.